I think 1, 2, 3, 4, 5, 6, 7, 8. We do yes, we do anyway. So we will start. Welcome to the Joint Standing Committee on Health Coverage Insurance and Financial Services. We have a number of public hearings to do this morning. And then do we have work sessions this afternoon as well, Colleen? Yeah, and then we have work sessions this afternoon, as well as some light language review at the end of the day. So we will be starting with LD 299. And then my intention is to take things in order, but we may go out of order if sponsors are needing to have some flexibility based on where else they need to be in the Zoom universe this morning. So we may move things around a little bit this morning, but we have pretty short hearings on a whole bunch of different bills that I think we'll get through this morning. So that's what the day's work looks like. We do plan to caucus over a lunch break. And I know I have to be in judiciary at 1 o'clock briefly as well. So there's some road bumps, but that's where we're headed. We'll start our introductions this morning with Representative Evans.
Okay, thank you, Madam Chair. My name is Richard Evans. I represent District House 120, including the towns of Atkinson, Brownville, Dover, Foxcroft, Medford, Milo, Orneville Township, and Lakeview Plantation.
Representative Quinn.
Hello, my name is Tracy Quinn. I represent 144, which includes Amity, Bancroft, Benedicta, Cary, Glenwood, Haynesville, Hodgdon, Holton, Macklahock, Molunkus, Orient, Reed, Silver Ridge Township, South Rustic, and Weston. Good morning.
Representative Arford.
Thank you very much, and good morning, Madam Chair. I'm Representative Poppy Arford. I represent District 49, the western part of Brunswick.
Representative Melrano.
Good morning, my name is Gina Melrano. I represent House District 62, which is part of Auburn.
Representative Brooks.
Good morning, my name is Heidi Brooks. I represent House District 61, which is part of Lewiston.
Representative Morris.
Good morning. I am Representative Joshua Morris. I represent House District 75, which is Turner, Leeds, and part of Livermore.
Representative Tepler.
Good morning. My name is Denise Tepler, and I represent all of the town of Topsom, House District number 54, and serve as the House Chair of the committee.
And I am Heather Sanborn. I represent Senate District 28, which is half of Portland and half of Westbrook. And we are assisted today by Colleen McCarthy-Reed from the Office of Policy and Legal Analysis, and Christian Ritchie, our stellar clerk. So we are going to first pick up LD 299 for a public hearing. It is an act to provide clarity in the laws governing the profession of counseling, brought to us by Representative Jay McCrate. Welcome, Representative McCrate, and go ahead.
Thank you. Hi, everybody. Love a committee that starts on time. That's so exciting. Senator Sanborn, Representative Tepler, esteemed members of the Health Coverage Insurance and Financial Services Committee, I'm Jay McCrate, representing Harpswell, West Bath, and Northeast Brunswick in the House. I'm here today to present LD 299, as you just heard, an act to provide clarity in the laws governing the profession of counseling. So this all started when I learned through a constituent who called with a concern that there's a problem with our counseling licensure statutes allowing some people who are unlicensed to practice as if they were. Though the details of my constituent situation are disturbing, I focus here not on that specific situation, but on the general problem of the loophole that has allowed this to happen. As a formerly licensed social worker and licensed clinical professional counselor, it honestly never occurred to me that anyone would practice without a valid professional license. A license confirms that the person has met certain qualifications and has committed to follow the ethical responsibilities and standard of care involved in the areas of practice for which they have been granted a license. When a complaint is received about an unlicensed person who purports to be qualified to practice counseling or therapy, or who acts as if they are qualified, the licensure board doesn't have the authority to act. It's a catch-22. The board can refer the complaint to the Attorney General's office, but that office has shared that it's not possible to pursue enforcement of such unlicensed practice due to the muddled statutes. And stated that, again in quotes, resolving this conundrum would require enacting legislation. I was advised that tightening up Title 32 is needed to address this problem. Under the statutes related to the practice of counseling, unlike that of social work or psychology, for example, the statutes are not as complete as they need to be. We need to add statutory language clarifying that a person may neither engage in the practice of professional counseling nor profess to be qualified to engage in such practice unless licensed to do so. This proposal does not change any of the exemptions that already exist, such as peer groups, support groups, clergy. And I've attached the reference to those exemptions in my testimony. The bill also makes it unfair trade practice for persons to present themselves as social workers, psychologists, or counseling professionals without a valid license to practice. In complicated family situations, which was the case with my constituent.
Yes.
Let me turn off the other
They
one.
went on a quick break while we were waiting.
Again, in complicated family situations, the courts may be involved in ordering counseling or therapy. Because of this, a third provision of this proposal specifies that when a court does so order, verification that the provider has the appropriate licensure for what has been ordered is needed. With a licensed provider, should there be a complaint, the board will be in a position to address it and determine action. And in some cases, if they need to refer to the Attorney General, such as in unlicensed practice, this language would allow the Attorney General to act. Thank you for your attention, and I'll do my best to answer any questions. And I just want to add, I talked with the AG's office this morning, and they made a suggestion that in the definition of professional counseling, it would be helpful to include for a fee to make it clear that we're not talking about protected speech. It's when somebody presents themselves in that professional capacity for a fee. I also want to thank your analyst for crafting the language of the amendment.
Thank you, Representative McCrate. Are there any questions for our colleague? My question was going to be whether you were talking about licensed or professional counseling, the definition of professional counseling, whether it should include the words for a fee or that you charge for, because I know that I've certainly felt like I was providing professional counseling at various times, whether because I was an attorney or because I was a high school teacher. Both of those things sometimes involve counseling. And I certainly have felt that way as a friend. So I guess I would ask, how do we draw that line, right? Where I'm often giving people advice. I bet all of my colleagues on this committee are giving people advice that other people are probably trained to give, but that for whatever reason, I'm the person giving. Can you speak a little bit to that?
Sure. Well, that's an important point. Thank you. And I think the difference is you're not setting yourself out as a professional counselor. Someone asks you for advice, you give advice, but you're not being paid for it. You're not exchanging, you're not bartering for it. You're providing advice. That's very different than someone who has a shingle with all the ethical standards that go into having that license. And it's you have training, you have education, you have take tests, you go through all the hoops to get licensure to verify that you're going to commit. You have been approved to provide that professional service, and you have agreed to the ethical standards, the standards of practice, so that when someone comes to you in that professional capacity, they should be able to expect that you are qualified to do that work. When someone comes to you as a friend, or I worked in public schools too, and had teachers come to me for advice, I wasn't their professional counselor or clinical counselor or social worker. I was a friend. It's very different. And again, to make sure, there are exemptions already in law that I don't want us to change. Those are already carefully thought out. That isn't somebody who needs a license, like a peer coach or intentional peer support or recovery coach or clergy. I'm not trying to go into that area. I'm just trying to say where someone has an expectation that someone that they're working with in this capacity is licensed to do what they purport, what they say they can do, or what they act as if they can do. They need the qualifications to do it.
Does that include, is there an exemption for someone who holds themselves out as a business counselor or a life coach?
Yeah, those would not be under, that wouldn't change. Those are not required to have this professional licensure. A financial advisor would need that kind of licensure, but not this.
Okay. All right, thank you. Are there other questions for the sponsor? Representative Arford.
Yes, thank you very much, Madam Chair, and thank you very much, Representative McCray, for being with us today. I want to make sure I understand what you're saying. You're saying that currently there's no recourse if someone engages in some sort of a potential, a supposedly therapeutic relationship, thinking someone was practicing social work or a professional counselor or whatever, and later found out they weren't, and was also for some reason dissatisfied with the service and wanted and desired some sort of recourse. As it stands right now, there would be no place for them to go where realistically they could get any help. And this bill changes that.
Thank you. Because boards oversee people with licenses, they can't act. They can refer to the Attorney General. But because in this particular part of Title 22, social work and psychology, for example, already say you can't act as if, you can't say you are. But counseling didn't include both pieces. Counseling is a newer profession. I was there getting my master's when the licensure for counseling happened. So, that was way after dinosaurs. So, but after social work and psychology had been in practice. So this is what was, again, when this problem came to me, the recommendation was you need to tighten it up in this area. It's already tight. And the boards can oversee, for example, social work, psychology, psychiatry, and medicine, but not counseling. It just needed to be tightened. And trying to close loopholes all over the place in this, because I look, as I looked at it, what does the AG need? What is if the court is ordering it, just make sure the person's licensed for what you're asking or mandating that they do. That's all.
Thank you.
Representative Quinn.
Thank you, and thank you, Representative McCray. This sort of follows up on what you just mentioned, where if a court were to order something such as that, but everybody involved in that family, say, wanted to go to clergy who may not have that particular license with the state, would they be still exempt, or would they be required then to go to someone licensed? I was confused about that in the wording that you mentioned earlier.
No, again, clergy is already exempt, as are quite a few other practices. As I mentioned, peer support, recovery coaches. There's quite a long list. And again, I attached it. This doesn't change that. If the court orders professional counseling services, professional social work services, work with a psychologist, perhaps for psychological testing, that's a profession that needs licensure. The others do not, and certainly it's somebody's choice where they choose to go. If you choose to go to someone who is from a profession that isn't required to be licensed. This does not change that. It's only when it's under what we all know and expect to be licensed practice that you can't present yourself as if you are. So a clergy person who could be licensed as a clinical professional counselor or a licensed pastoral counselor, but if they are not and they present themselves as a licensed clinical counselor, they aren't unless they're licensed. So I'm kind of going around in circles, but it doesn't add any exemptions that aren't already in it. It keeps all the exemptions that are already in law. It's just trying to tighten up that you have to be honest. If you say you're licensed, if you say not if you say you're licensed, if you say you're qualified to do this practice that requires licensure by statute, then there has to be a mechanism if there is a complaint. And right now there is not. It falls through the gaps. The boards can't address it because it's not a licensed person. The AG can't deal with it because the statutes aren't tight enough.
Can I follow up with one more question?
Sure, go ahead.
Okay, so I still am missing a little bit of part. So if the court does say that they want you with licensed professionals, then that would be the exemption that you have for pastoral care would not qualify. They would have to choose a different source, even if they wanted to go with pastoral care. Is that correct?
Well, I'm not a lawyer, but I think that I would assume this would be a conversation. When I visited family court, there are lawyers there, there's discussion. The family might say, I would prefer to go with clergy. The judge, however, does have the authority to say, I want you to have X. But the family would also have a voice. I would also add that if the court did order, doesn't mean you can't do other things.
Would this bill put it in statute then, though? That's my question.
Put what in statute?
Put in statute that if it were court ordered, it would have to be a licensed person, because I did before you mentioned it earlier.
Well, I don't. What it means is that if the court ordered intervention that is typically a licensed practice, that person that they order to do that service would have to be a licensed person. If they're, I don't know if a court would ever order that you would see clergy. I don't think so. That would be your choice. If they recommend, for example, treatment around substance use disorder and you choose a recovery center, recovery coach, they don't require a license. It's only, the case that came to me was a case where there was a court involvement and the court ordered intervention. The problem is the ordered intervention was not with a licensed person, and the disruption that came later there's no recourse for the family to act on it.
Okay, so I think you just answered my question then. If the family did want to go to someone that wasn't licensed, but the family was choosing that, would disqualify the family from being able to choose their choice in the future because they would have to go with someone that was licensed.
No.
Okay. I'll have to, I don't want to hold up but from what I'm understanding is you're stating that the bill is because they went to a person that wasn't licensed and they have no recourse. And so you want it to be someone who's licensed, but then I'm asking about clergy that's not licensed, that if they were to choose to go to them, they would have to be forced to go to someone who's licensed with that part of the bill in there.
That's thank you for that. It's not the intention at all. It's not to restrict somebody's choices of what they choose to do to go for assistance. If you choose to go to someone who offers some service that doesn't require a license, that's not a problem. If you have a complaint about what happened, you wouldn't have a licensure board to go to. And that's not what I'm getting at either. This is someone who presented, I am a child therapist. I provide child therapy. I provide child counseling, but they're not licensed to do that. And that requires a license. Clergy does not. The other issues I've listed do not. You might want to look at the list of exemptions and see if that helps, because I wanted to be very careful that we weren't doing anything about changing what's already exempted. For example, clergy, they're already exempted. And it's not to take away people's free choice. It's to say, if you are led to believe this is a person qualified to do this work under the licensure statutes and they're not licensed, we need recourse.
Okay, I absolutely do get that. But the question still is, if someone then has to, it's stating that if someone has to go to someone who's licensed, that is keeping them from going to someone of their choice if that person is not licensed. Do you see what I'm saying? Ordered that they need licensed counseling. They would not be able then to go to clergy unless that clergy was a licensed counselor. Am I reading that correctly? That's where my concern is.
Yeah, I understand your concern. I don't share that concern because the person can go to wherever they choose to go. If the court orders, say it's a family with, maybe they're under a protective order,
Mm-hmm.
and the court orders that the family do some counseling work, they would be required, I would like that to be required of someone. You need to do counseling, clinical professional counseling, clinical social work to deal with the whatever caused the protection order. That doesn't mean that they can't also go to clergy, but they would need to do the work to whatever it was that brought them to a pretty serious situation if you're in court typically. But it doesn't take away other choices.
Thank you. I did get the answer to it. Thank you very much.
Thank you. Representative Tepler, go ahead.
Thank you, Madam Chair, and thank you for being here, Representative McCreight. I just want to ask a clarifying question from my understanding of the bill. So we have a couple of kinds of forms of licensure among our boards of licensure. Some of them are licenses that include not just the title is licensed, but the actual practice is licensed. And right now, under our current system, the Board of Professional Counseling is a title licensure. And what you want is for it to become a practice licensure, so that that practice is actually governed by the board, not just the title professional counselor.
Right.
So that is what I'm looking at clarifying. That is the main intent of the bill, correct?
That's right.
Okay.
And would bring it into alignment with similar practice, social work, psychology, which already has that. Social counselor got left out. Want to put it in.
Thank you.
Thank you.
Okay, are there additional questions for Representative McCreight? All right, seeing none, thanks for bringing this to us. And next we'll hear from Dana Prescott. Good morning. You can go ahead, Mr. Prescott.
Good morning. Thank you, Senator Sanborn and Representative Tepler and honorable members of the committee, and to Representative McCreight for her work on this legislation. By way, briefly, of background, I'm a lawyer in Saco. I've been a lawyer since 1983, and because of the nature of this bill, I wanted to also say I hold an LMSW, that is, I have a master's in social work. I also have a PhD in social work and teach as an adjunct, as well as being a trial lawyer and a guardian ad litem. I mentioned those factors because there are a couple of points about this legislation that are important. Right now, in our court system, people can come from out of state or in state and come into court, and if a judge determines that their testimony has some merit based upon the admissibility of expert testimony in Maine, they can give opinions, and those opinions can include diagnosis of people they've never met, or recommendations for treatment in reprogramming facilities out of state, which is what Representative McCray was alluding to. Presently, and I was really unaware of this until a recent run of cases over the last 3 years in the courts in Maine, there is a gap in two aspects of the law. First, if you hold no license, but you testify that you have experience working with families, for example, you can come into Maine. A judge can hear your testimony and give it considerable weight in the kinds of cases that come before the family court. If you testify to your expert opinion based upon materials or research that would otherwise be unethical if testified to by a social worker or a clinical professional under their ethical codes, there's no recourse. That is, if you don't hold a license, the licensure board currently has no jurisdiction or oversight over unethical practices. That is, practices that would be unethical for social workers, psychologists, counselors. In addition, the Attorney General's office has authority, for example, over the unauthorized practice of law. If I'm not licensed as a lawyer in Maine and I come into the state, the Attorney General could take action against me for that unauthorized practice by statute. In Maine, however, a person licensed perhaps in another state can come into Maine who may hold a clinical social worker or counseling license, act in that capacity by giving a diagnosis of somebody or testifying as an expert opinion. And the Attorney General's office has no authority over the unauthorized practice because they don't currently hold a license. So those two gaps in the law have created a kind of industry of people who travel from state to state, giving opinions in family court matters about adults and children and parents in incredibly powerful ways. I know this is really difficult sometimes to explain because these cases are so incredibly painful, but I heard the question regarding therapists, for example. The therapeutic community and the licensure part of the bill is fine. Occasionally, you'll see somebody hold themselves out as a counselor who has no license or people don't know. Presently, if somebody did that, this fills that gap in that statute. That is, if I represent myself as being a therapist or a counselor and I don't hold a license, I could have action could be taken under this legislation for that, as well as by the Attorney General's office for unauthorized practice, again, just as they could to a lawyer who did the same thing from out of state. The real problem in some of this is in the forensic capacity, that is giving expert opinions in court. So for instance, a forensic psychologist who comes from New Hampshire or Michigan to testify in Maine understands under the APA Code of Ethics that they are bound in Maine by Maine's ethical codes and bound by that by virtue of their license. There are many other people, unfortunately, who come into the state and other states for that matter and provide expert opinions and will testify in court that they're not really bound by any licensure standards. They're testifying based upon their experience and give opinions. Whether or not judges should be admitting those opinions is a different discussion. But right now in Maine, what Representative McCray has been working on along with others is legislation that would fill the gap in two ways. If you come to Maine and you're going to engage in any kind of practice that fits within the definition of counselor or clinician, you're going to be bound by the ethical codes that bind those professions and be supervised in that way by the licensure board, as indicated in the testimony that I read. The second part is that the Attorney General's office would have some oversight authority if they determined, either under the unfair trade practice or the statute, that somebody was engaging in the practice of counseling, therapy, diagnosis, outside of licensure or without a license, and would be able to take action in appropriate cases. And so what this legislation really does is create for Maine citizens protection from a licensure board perspective and for the Attorney General's perspective in cases in which there may be lapses or abuses of somebody's representation of their licensure status, of their giving expert opinions that you can't give. That is, you can't give a diagnosis, for instance, without holding certain licensure. As an LMSW, for example, I can do a lot of work in social work, but I can't bill and I can't do diagnosis. There's a limit on my license under state.
Thank you, Mr. Prescott. Can you wrap it up for us?
Oh, I'm sorry. I didn't. I was looking at, yes. So, and my closing remark is simply that I testifying in favor of this legislation. I think it's important and fills a gap that assists families in Maine. Thank you. Thank you for the opportunity for being here.
Thank you for your testimony. Are there questions? All right, seeing none, pardon me. I will ask if there's anyone else in the Zoom meeting who wishes to testify on this bill. Please raise your hand at this time. All right, seeing none, I'll bring the public hearing on LD 299 to a close, and the work session will likely be scheduled for early May. Okay, let's see who else we have for sponsors. And I see Representative Perry, and it's a different screen to figure out which bill is Representative Perry's bill. So bear with me for just a moment. We'll bring Representative Perry in. And the next bill we will hear will be LD 749, which is an act to establish a council on health systems development, presented by Representative Perry. Welcome back to HCIFS, Representative Perry.
Good morning.
Go ahead.
Okay. Good morning, Senator Sanborn, Representative Tepler, and members of the Committee on Health Coverage, Insurance, and Financial Services. I'm Representative Ann Perry, and I represent 9 communities in Washington County. I'm here to introduce LD 749, an act to establish a council on health systems development. I bring this bill forward for many reasons. First, during my time in the legislature, I know of 3 ad hoc committees who met in the past regarding healthcare coverage and access. They have held 4 to 8 meetings to find answers and make recommendations to the problems expressed. Follow-up, however, was sketchy and limited. Second, we in this country say we have an excellent healthcare system, yet we manage to have one of the highest morbidity and mortality rates in the developed world. Third is my conclusion that we have services that are good, but we do not have a system. We have healthcare silos who do not always work together. I feel we can do much better if we create a system of continuous communication to work together as a system, thus creating the ability to control the cost and outcomes of our healthcare system. I understand that you have the amendment that I propose to accomplish the above. This amendment proposes the following. 1, to create a permanent council on health systems development with 15 members representing all areas of healthcare, including consumers, business, DHHS, and 5 members of the legislature. This is modeled after a similar council that was enacted in 2004 and worked for 7 years. I was able to participate in that work. The work of the council includes collecting and coordinating data on health systems development in this state, synthesizing relevant research, conducting a systemic review of cost drivers in the state's healthcare system, collecting and reporting on healthcare costs and indicators, identifying specific potential reductions in total healthcare spending without shifting costs onto consumers and without reducing access to needed items and services for all persons, regardless of individual ability to pay. Beginning in March 1st, 2023, to annually make specific recommendations to the joint standing committees of the legislature having jurisdiction over health coverage and health insurance matters, and the joint standing committee of the legislature having jurisdiction over health and human service matters, and to any appropriate state agency. I believe with a continuous look at all the aspects of our healthcare, we in Maine can ensure that the citizens of Maine can have improved access and outcomes regarding their health. I thank you for this consideration and will answer any questions you may have.
Thank you, Representative Perry. Are there questions for Representative Perry? Representative Tepler.
Thank you, Madam Chair, and thank you for being here, Representative Perry. Representative Perry, we've heard a couple of bills on organizational structures to improve affordability and understanding of healthcare practices in Maine this year. I'm just wondering about how you see coordination of those. What I really don't want to do is create silos of information within the different structures that we have. So I'm just asking if you see us as being able to coordinate those structures.
Well, my hope is, and I will say it's a hope, and having worked on a committee that had a very similar structure, is that it's the communication between all of the aspects of healthcare, where they're talking with each other as well as the legislature is looking at what this looks like, that we gain coordination with the data and structure we can look at. We can also try different things, and we did at one point that we had done cost drivers and looked at emergency room admissions. And actually with the hospitals and providers, we talked about trying something out, and this was voluntary. And we did this over a 2-year period and then restudied admissions and what had happened with them. And as a result, we were able to cut admissions to the hospital from the emergency room that were deemed unnecessary. And the outcomes were, good for the consumer. They were also good because these were unnecessary hospitalizations, and we saved money in the system. This is talking about everybody looking at the data. This is talking about everybody talking about the data and working together to see what we can do. And if this is something we can do on a regular basis, we got bills that come up that, are looking at, what am I trying to say? Doing universal health coverage. Well, universal health coverage may help with access, but it doesn't help with the cost of healthcare. We've got to look at coverage plus healthcare. This is why I'm really looking at, and actually I think we should add dentists to this, but I didn't put it in there. But we need to look at the whole system with the people involved in the system so that we know where the areas are that really can make the difference. And that's really the purpose of putting this kind of a council together.
Thank you, Representative Perry. Representative Perry, can you remind me again which council it was that you referenced in your testimony earlier that existed and no longer exists?
It was called the Council of Healthcare Systems Development.
Oh, okay. Okay. Representative Arford, go ahead.
Yes, thank you, Madam Chair. And thank you so much, Representative Perry, for being with us today. I have a great deal of respect for the work that you have done. And I would actually like to know a little bit more about the work of at least I think you referenced 3 different ad hoc committees that you either served on or were aware of. Would you be able to make any reports that these committees produced available to us? That's my first question.
Well, yeah, actually, the one I was involved in, I was with Senator Sanborn, it was called Healthcare for All Mainers, and we met. I think I don't know how many times we met, but we ran out of time, and I think that's the other piece that goes with it. We were doing some good side work, and we came up with a couple of things that we could do in the process, which we were able to succeed at. But there was so much more we could have done. The health data bill that I brought forth came out of that committee. And there was a PBM bill that came out of the work with that committee. Those are only pieces of it. And there's, with an ongoing ability to have these conversations go on, we could really do much more. The Council on Health Systems Development that I was involved in was intended to be ongoing. It was dismantled at one point, and unfortunately, I think that it was doing the work that it needed to do, and I think it needs to be back in place. The other committee that I am aware of was before the first time I came in, and they brought forth a pretty significant report that was paid for. And that was in 2002, that report came forward. And I don't think anything came out of that report. So, my feeling is if you have something ongoing, somebody looking at all of this and continuing to look at this, then we've got somebody looking at, are we doing what we need to be doing? Are we progressing where we need to go? And if not so, what do we need to do? And that can't be done in 8 meetings.
Thank you so much. And then, so am I correct in thinking that this bill, that a lot of learning occurred as a result of previous groups, that the previous convening of these ad hoc entities, and that learning is demonstrated in the way this bill is designed to avoid the pitfalls of these previous groups?
Well, here's my hope. I mean, these are ideas, and my hope is that it can succeed.
Representative Evans.
Thank you, Madam Chair, and thank you, Representative Perry, for bringing this together. From what I'm gathering, there has been groundwork already laid to come to this point. Are you aware of any current bills of a like nature, getting back to what Representative Tepler was concerning?
Well, I have an understanding that Senator Jackson brought forward a bill to create, I don't know if it's exactly similar to it, but sort of an idea of a permanent council of some kind. I can't remember what the title was.
It's the Office of Healthcare Policy.
Okay, yeah.
Okay, so but the groundwork is there, and what you're trying to do is to expand on what we have already developed to see if it will work with report back and information as you get that information,
right,
for the legislature.
Yes, and I also think, I did read over his bill, we need the kind of input that involves the whole system.
Okay.
That's why the committee that's designated is really bigger. And it's because we need really not the silos. We need to bring all of those pieces together so that we can really, sometimes we work with the healthcare system. We try to put something somewhere, and unfortunately, it's like squeezing a balloon. It pops out someplace else because that cost gets shifted. So what we've got to look at is the whole system to make sure that what we intend to do, we're doing. And so I think having that participation is important.
Thank you. You've answered my question.
Okay. So Representative Perry, my question is this. I have chaired, the most recent of these organizations that was not intended to be permanent. We did put out a report that we've now actually enacted every single recommendation in the report, which is kind of cool. But the big problem is there's no executive director referenced in your bill. There's no staff. There's no paid person at all contemplated in the bill. And how is it possible to do this type of work if no one is being paid to have it be their job to do this type of work?
Well, it was the intent that that paid position would come out of DHHS.
Okay. Are there questions, other questions from the committee? Representative Quint, go ahead.
Yes, thank you, Madam Chair, and thank you, Representative Perry. I'm just wondering, I guess this would be the elephant in the room, and I might get a smackdown for this, but a lot of our healthcare, the cost in the state of Maine is because we do have an obesity problem here. And I'm wondering, when we get all of the data, does anything forward to actually tackle the underlying problems, or are we just making the healthcare in our state larger and larger and having more and more bureaucracy behind it? I'm just kind of wondering, like, if this committee would be tackling that sort of thing, recommendations going out, and if that could actually be addressed, if this is the right area that would be addressing it.
Well, prevention is part of healthcare, and prevention has to be part of, and we have that in the list of people on the council, that prevention has to be a part of that. And we already have a state health improvement plan that is being followed with our health systems, our prevention systems. But what we need to do is, are we spending enough, and I will say spending enough and paying enough attention to prevention as compared to the rest of it? Are we, but we can't pit one against the other if we're not working together. And that's the piece that I'm really looking at.
Thank you very much. I just wanted to make sure that it was being all inclusive for that, to try to bring it down, because I just see them skyrocketing, and I know many people are concerned with it.
Yeah.
Representative Arford.
Yeah, quick question. I just reviewed the amendment. Thank you for providing it. And it calls for the appointment of 2 consumers, and yet there is no definition that I could find whatsoever of consumers. So I would ask that that be in some way addressed in this bill, because I think it's needed. Thank you.
Okay. Are there additional questions for the sponsor? All right, seeing none, we thank you, Representative Perry, as always, for joining us at the committee. And next, we'll hear from Jeff Brown. Good morning, Mr. Brown. Please unmute yourself and go ahead.
Great, thank you. Yes. Madam Chair, members of the committee, my name is Jeff Brown. I'm a resident of Belfast, and I'm testifying in support of LD 749. I am testifying principally to make some suggestions that have been reinforced by recent work in rural Maine. I've worked in healthcare improvement nationally for more than 20 years, and most recently I've worked with rural healthcare providers in Maine for the past 6. In 2020, as the pandemic deepened, I co-led a study in Washington County that, among other purposes, elicited patient, provider, community group recommendations to mitigate health disparities that have been exacerbated by the pandemic. We were looking in particular not for just what would matter locally, but what can be levered for improvement statewide. We interviewed EMS, public health, health centers, tribal health centers, dental services, mental health, behavioral health, hospitals, community groups, higher education in Washington County. We took a systemic look at how folks in Washington County are trying to address barriers to improving preventative care and access to acute care. We had specific changes relative to scope of practice, payment rules, payment models, workforce composition, alternative models of care, resource sharing, and more. What we learned that pertains specifically to LD 749, we identified core Washington County alliances comprised of the aforementioned kinds of healthcare organizations and community groups that have self-organized to innovate, integrate, and coordinate to meet community needs. They're creating an economy of scale, developing sustainable services, and troubleshooting emergent needs for health and healthcare for their communities. I have encountered similar regional groups elsewhere in the state. These are self-organized de facto regional coordinating entities. They're interprofessional, interorganizational. They're breaking down silos, working in an integrated way as learning health organizations. They have a wealth of knowledge to guide state level policy in support of communities. This same capability is needed on a statewide scale, which is why I am strongly in favor of this legislation put forward by Representative Perry. We need a central state-focused learning entity or node to consistently elicit, accept, and process data and insight from these regions of the state to inform policy and regulation, and also to conduct prompt revision of policy and regulation that has unanticipated negative effects on healthcare provider operations and patient experience. So my concept of the Council on Health Systems Development may veer from that of sponsors, but I suggest that a council could function as a central learning node in the state tied with regional coordinating entities. There are many capable people in this state attempting to integrate efforts.
Thank you, Mr. Brown. Can you wrap it up for me?
Yep. And the final statement is I suggest a governance structure for this council should get equal weight to all representatives, regardless of each type of organization's financial or geographic footprint. Thank you very much.
Thank you, Mr. Brown. Are there questions for Mr. Brown? All right, seeing none, we thank you for joining us and providing testimony today. Next, we'll hear from Charlie Dingman. Mr. Dingman, go ahead.
Thank you, Senator Sanborn and members of the committee. My name is Charlie Dingman. I am with the law firm of Kozak and Geyer, and I'm here today representing the Maine Primary Care Association, which is Maine's association of community health centers. Those health centers make up the largest primary care network in the state and provide a wide range of health services, particularly to underserved communities, without regard to the patient's ability to pay. The association strongly supports Representative Perry's initiative here to create a permanent and wide-ranging council to focus on health system development and cost drivers. We also note the similarity between the objectives of this bill and President Jackson's LD 120, which the committee has already discussed with the sponsor. I think in light of that, our working assumption as we looked at these two bills was that the committee would likely look at them together and probably try to draw from the strong points of each of them, including a thoughtful choice about what kind of staff support is feasible and most effective for the legislature. I did want to comment on a couple of specific voices that the association believes should be specifically recognized in the council that you form in response to these measures. Those perspectives are, not surprisingly, related to the work of the community health centers. We would emphasize that primary care, and particularly the FQHC model of delivering an integrated, comprehensive kind of primary care in underserved areas, is a perspective that it's very important to include in a council of this kind. And we would urge that, and there are a number of ways this could be done depending on the final form of the council, but that a representative of Maine's community health centers be included, along with the representatives of various other provider types that are called out here. And likewise, we support Representative Perry's reference to dentists as a very important perspective that needs to be included. Oral health is clearly a vital component of overall healthcare and needs to be treated as such. Those are our primary comments, and we urge you to support the development of a permanent council of this nature to address these issues. Thank you, and I'd be happy to answer any questions that you have.
Thank you, Mr. Dingman. I see that Representative Evans has a question. Please proceed, Representative Evans.
Thank you, Madam Chair. Just one question. You refer to community health centers to be distinguished from FQHCs. Am I correct?
No, Representative Evans, they are one and the same. The association frequently refers to Maine's FQHCs as community health centers.
Thank you.
Okay. Any other questions from the committee for Mr. Dingman? Mr. Dingman, this committee has also heard a bill from Senator Jackson, I believe it was last session, regarding an affordability board that we enacted. Do you see integration of the affordability board with this or whatever council we may end up with?
I hadn't specifically considered that in developing the association's testimony today, Representative Tepler, but I think it's very hard to argue that there should not be integration of those initiatives. Both LD 749 and LD 120 really focus on cost and price issues. So I think that all of these really are driving at the same fundamental policy problem that needs closer and more sustained attention.
Thank you, Mr. Dingman. And I see Representative Evans, do you have another question, or is that just, as Senator Sanborn says, a residual hand? Thank you. All right, thank you, Mr. Dingman. And next up, I believe we have Mr. Moran. Speaking in favor of the bill. Welcome, Mr. Moran.
Good morning, Representative Tepler, and feel free to call me Dan, you and Senator. My daughters told me how much gray hair I had the other day, and when I hear Mr. Moran, I always think I'm falling apart anyway, so Dan would be great. Thanks. We're here to support the bill.
Mr. Moran, just to interrupt you and for the public's consumption, we call people formally by their titles here so that we can create some level of equality and make sure that we're not being overly familiar with people we might know who come before us. So,
sure.
So we'll continue to call you Mr. Moran, probably.
All right, great. Makes me think of my dad, though. Thanks.
Well, you know, since I'm older than you are, I'm not going to worry about that much.
Thank you.
Please
go ahead.
ahead.
Little levity is always good. Thanks, Representative Tepler. So we support the bill, and much like Mr. Dingman just mentioned, we have a friendly amendment suggestion. If you look at the end of section 1A on the top of page 2, it talks about how the governor shall seek nominations from certain statewide associations, and it actually deliberately mentions physicians, but in the construct of the composition of the entity, there is no formal seat at the table for anyone from a physician organization. It does touch on mental health, talks about financing, public health, but there doesn't seem to be a whole lot of membership in the people closest to the patient and the provision of care. So we would recommend that the following be added to the bill. It's in my testimony. One individual who represents a statewide association of physicians, or whatever Colleen thinks the appropriate language is. We just believe that physicians/clinicians need a formal decision-making seat at the table in any process and discussion on the future of healthcare in Maine, especially non-hospital-based independent community physicians. We've been helping them throughout the pandemic, although most of our members are involved in hospitals and health systems or employed by them. We do have a significant segment of non-hospital based independent community physicians that provide care to patients all across Maine. So thank you for the opportunity to comment. We'll take any questions.
Thank you, Mr. Morin. We just handed the gavel back. So are there any questions for Mr. Morin? All right, seeing none, we thank you for your testimony. Is there anyone else in the Zoom meeting who wishes to testify verbally in favor of the bill? Seeing none, is there anyone in the meeting who wishes to testify in opposition to the bill? Seeing none, I will call on Catherine Pelletreau, neither for nor against. Good afternoon.
Good morning. Senator Sanborn, Representative Tepler, members of the committee. My name is Catherine Pelletreau. I'm the Executive Director of the Maine Association of Health Plans. I'll be very brief because our testimony today is similar to what we provided on LD 120. We're generally supportive of efforts to do a deeper dive into what is driving high healthcare costs in the state of Maine. In particular, this bill calls out a few issues that we're especially supportive of looking more deeply at. One is cost drivers, key components of the total cost of healthcare, cost shifting and the volume of uncompensated care, the geographic distribution and regional variation in cost and quality of services, and the growth in utilization of healthcare services. We do want to add one note of caution on administrative costs, that if administrative costs are going to be a topic for the group, there needs to be a really thorough examination of them, particularly in the differences between public and private payers and what is encompassed in the definition of administrative costs for either category. We remain concerned about duplication of effort and additional costs associated with new data requests. But otherwise, we think this proposal and proposals like it are important to consider and have promise for improving healthcare costs and quality for Maine people. Thank you.
Thank you, Ms. Pelletreau. Are there questions for Ms. Pelletreau? All right, seeing none, thanks for adding your voice. And next we'll hear from Ann Robinson. Good afternoon, Ms. Robinson, go ahead.
Thank you, Senator Sanborn, Representative Tepler, members of the committee. My name is Ann Robinson. I'm a lawyer with Pierce Atwood, and I am here on behalf of Spectrum Healthcare Partners. So we certainly agree and support the notion that we need to, as a state, to continually work on healthcare costs and looking at what the drivers are in the healthcare system. And to that extent, we certainly, support this initiative. However, we also recognize that, whether a permanent council is the way to go or the more, traditional approaches of the ad hoc committees, we are agnostic to that particular choice. But what I do want to emphasize, and kind of picking up where Mr. Moran left off in noting that physicians aren't included in the enumerated participants, that it's really important that if a council like this is going to be established, or whatever the vehicle is for looking at healthcare drivers, that it reflect the various means in which healthcare is currently being delivered in the state. And for example, there are alternatives to hospitals, and there's a significant role that ambulatory surgical centers play in the delivery of healthcare. For example, imaging services are provided in various kinds of venues. So again, if regardless of the particular body or entity that the legislature might create to take a more comprehensive, holistic look at what's driving healthcare costs, we think it's really important that the members of that body be truly representative of how healthcare delivery is being delivered in Maine today and might be in the future. And I'd be happy to.
Thank you, Ms. Robinson.
This language. Thank you.
Thank you, Ms. Robinson. Are there questions for Ms. Robinson? All right, seeing none, we thank you for adding your voice today. There's no one else signed up to testify in this particular hearing. So if there's anyone else who wishes to speak, please raise your electronic hand at this time. And seeing no electronic hands go up, I'll close the hearing on LD 749, and we'll open a hearing on LD 365, an act to protect consumers from surprise medical bills. And Representative Morris hopefully is there. He is there, so go ahead.
All right, thank you, Madam Chair. Senator Sanborn, Representative Tepler, distinguished fellow members of the Joint Standing Committee on Health Coverage, Insurance, and Financial Services. My name is Joshua Morris. I represent the people of Turner, Leeds, and Livermore. Today, I present to you LD 365, an act to protect consumers from surprise medical bills. As a committee, we have been committed to ensuring that consumers are held harmless from surprise bills. This bill builds on that work by enacting further consumer protections. Medical debt is one of the leading causes of bankruptcy in the United States. When someone does all the right things, they have health insurance, pay all their claims and deductibles, they should not have to worry about their credit being wrecked because of an emergency and an out-of-network claim. This bill is based on a Texas law that was passed in 2019. While I understand this may create issues due to federal preemption with credit reporting, I believe we should always work to help those people avoid unnecessary debt. As a realtor, I know firsthand how credit issues can affect a person's ability to plan for the future. I developed this bill as well as LD 750 and 751, which we'll hear later today, with Joel Allenbaugh of the Allenbaugh Agency. And I would refer you to his written testimony on this as well. Unfortunately, due to a conflict, he could not be here today, but will be available for work session to answer questions. And I can also, any questions I can't answer, I'd be happy to find out more as well. And I thank the committee for their consideration of this bill, and I'd be happy to try and take any questions anyone might have.
Thank you, Representative Morris. Are there questions for Representative Morris? I have one. So I'm trying to figure out exactly which bills would be covered by this. And I'm wondering if they're old bills. Are these bills that don't exist anymore because it's not legal for balance, for at least for Maine healthcare facilities,
Yeah.
excuse me, to balance bill for out-of-network claims on that are emergency medical treatment?
Right.
So, or is it trying to capture out-of-state companies that might balance bill?
Yes, I mean, anything that would not be covered by current laws, I think is what I'm really trying to capture, is making sure it doesn't get put on a credit report. is really making sure people don't, again, it's really about people who have done the right, as I said, done the right thing. They have their health insurance. They pay their bills to then be stuck with having their credit ding potentially. But I know we have done a lot in this area, and so I recognize that it may not be entirely needed for in-state things. I recognize that.
Okay.
Yep.
Okay, Representative Tepler, go ahead.
I just have a question about the use of the term health benefit plan. I think that that means health coverage, health insurance, but
yes.
to me it sounds like it's necessarily tied to employment, but I'm not sure of the legal definition of health benefit plan.
Okay.
Because you want this to be available, I assume, to those who are insured on the marketplace and other places where they're not insured through their employer. And my concern is that the term health benefit plan implies a level of employment or employer provided insurance.
Right. I understand what you're saying. No, the intent is anybody who has a health insurance plan. That is the intent. I appreciate that clarifying question. The intent is any health insurance, anybody who is covered under health insurance, a qualifying plan. Yes.
We can get Colleen to help with that language during the work session, Representative Tepler. Okay.
Thank you.
Great. Are there additional questions? Representative Matheson.
Thank you, Representative Morris, for your bill. Always looking to try to decrease surprise billing for sure. I'm just curious. I apologize. I didn't get to read this amendment just recently, but I'm looking at owed for emergency medical treatment. Are you just specifically looking at emergency medical treatment?
Yes.
Okay.
For the most part, yes, because that's where the consumer really doesn't have a choice in where they go. If if you get sideswiped in an accident, you may not be able to go to something that's in your network. So we're really trying to prevent those situations.
Are there additional questions for the sponsor? All right, seeing none, I will ask if there's anyone else who wishes to testify in favor of the bill. And as Representative Morris noted, there is written testimony from Joel Allenbaugh that's in our committee files. But seeing no other hands go up, we'll turn to those in opposition to the bill, and I'll call on Charlie Sultan. Good afternoon, Mr. Sultan. Go ahead.
Thank you, Senator Sanborn, Representative Tepler, members of the committee. I am Charlie Sultan. I am an attorney here in Augusta, and I represent CDIA, which is the Consumer Data Industry Association. And just in shorthand, they are primarily the three large credit reporting agencies. We are in opposition to the bill for two principal reasons, and both are detailed in the testimony over the signature of Mike Carone of CDIA. So I hope you get a chance to read that. First, and briefly, the three credit union agencies entered into a what's called a assurance of voluntary compliance with Maine and 30 other states back in 2015, dealing with reporting of credit and medical information. And we believe that that agreement would be violated by the proposal from Representative Morris. More importantly, and as some of the veteran committee members may remember, there have been two previous amendments recently that attempted to deal with medical debt reporting. CDIA, those bills were passed. We argued that they were in violation of what's called FCRA, which is the Fair Credit Reporting Act. Because the bills were signed, we did go off to federal court to challenge those amendments as being preempted by the federal law. And back in October of 2020, just a few months ago, the federal court in Maine found that, in fact, those two amendments were preempted by the federal act and therefore could not be implemented. We believe, for the very same reasons, that this particular bill, which attempts to regulate on a state basis medical debt reporting, would violate FCRA again for those reasons. I'm glad to share that decision with the committee if they wish to have it. It's simple. It was a well-reasoned decision by Justice Singal. It is on appeal to the First Circuit by the state of Maine, but we're fairly confident that it will be upheld. In talking with Representative Morris, and I appreciate the discussion we had, he believes that this may also be based on some Texas law. That bill is also been challenged. Its decision is not too far, we believe, from being decided, but we believe strongly that it will be also tossed out. There have been 4 cases across the country on similar bills. All 4 have been found to be preempted. So as laudable as the bill is, the federal government has found that debt reporting and credit reporting needs to be uniform across the states, and anything that interferes with that that's not done by the federal government would be preempted. So with that, I will end and glad to answer any questions.
Thank you, Mr. Sultan. Are there questions for Mr. Sultan? Representative Tepler, go ahead.
Thank you, Madam Chair. So, Mr. Sultan, if I'm hearing you correctly, we have no jurisdiction at all over credit reporting or credit scores in the state of Maine. So there's nothing we can do to help our constituents who are having a terrible time with medical debt.
It is limited. I'm not saying there's nothing you can do, but it's very limited because very recently the federal government actually acted on the medical debt dealing with veterans medical debt. And based on that, the federal judge found that, in fact, Congress had an opportunity to do more, didn't, and therefore didn't believe that any other state action would be appropriate. So I believe it is limited what you can do on a state level.
So limited to what?
Well, I'm not a massive expert on FCRA, but it is, you have to stay within the confines of how FCRA deals with the reporting of all kinds of information that goes into credit reporting. I can try and give you a broader and better answer, but I mean, it's very clear that in the court's decision, he took a what's called the expansive view of what the federal government has decided to do on this medical debt reporting. And so it seemed to limit quite broadly what states are allowed to do that deviates from what is already there under federal law.
I would truly appreciate your consulting with your colleagues who may be experts in FCRA and letting us know what it is that as a state we may have control over so that we can help our constituents with this issue that has become incredibly important, particularly since the pandemic.
Representative Evans.
Thank you, Madam Chair. Just to follow up on Representative Tepler's concern, I would also be interested in the type, or if there is a specific type of medical debt that is either included or excluded. Because
So
I think
if you look at, I'm sorry.
Representative Connor was speaking, I think, primarily, Representative Morris was speaking of emergencies, if I recall that to be correct.
If you go to page 1 and a little bit of page of my report, and I can get the larger agreement perhaps, sort of talks about what the what's called the AVC allows for medical debt. So, currently medical debt is prevented from being reported or displayed if it's identified and furnished by collection furnishers, they're called, when the date of their first delinquency is less than 180 days prior to the date that the account is reported to the credit reporting agencies. And then we have to have implemented a process designed to, in essence, remove or suppress known medical collections that are furnished by these collection furnishers from files within our respective reporting databases when such debt is reported as either having been paid in full or by insurance or as being paid through insurance. So I would direct your attention to that agreement and a couple of paragraphs on that. That's, I think, addresses some of what Representative Morris is trying to address.
Thank you.
Are there additional questions for Mr. Sultan? All right, seeing none, I will ask if there's anyone else who wishes to testify in opposition to the bill. Seeing no hands go up, I will turn to those neither for nor against the bill, and we'll hear from Superintendent Lund. Good afternoon. Go ahead, Mr. Lund.
Thank you very much, Senator Sanborn, Representative Tepler, and members of the committee. My name is Will Lund, and I'm Superintendent of the Bureau of Consumer Credit Protection. Part of the responsibilities include administering Maine's Fair Credit Reporting Act. In its current form, the bill would prohibit a credit reporting agency from reporting a medical debt under certain circumstances. The concept of the bill is, in fact, a laudable one. An insured person should not be penalized if their insurance does not cover a medical debt resulting from a health emergency. The problem, however, as you've heard from Mr. Sultan, is that the bill attempts to tell credit reporting agencies what they can and cannot put in consumers' credit reports. In addition to state credit reporting laws, there is a National Fair Credit Reporting Act, and that federal law does put some limits on what states can do in certain areas. In other words, states are preempted from taking certain actions. One of those preemptive areas relates to a state's efforts to put restrictions on what can be listed in a consumer's credit report. Congress's apparent thinking is that state credit reporting is a national business, so certain basic rules must be consistent from state to state. For example, if the bill becomes law and a Florida resident moves to Maine with a medical debt on his or her report, would the law apply? This is a very real situation, as Mr. Sultan has indicated. This committee in 2020 did consider LD 110, an act regarding credit ratings related to overdue medical expenses. That bill became law as Chapter 77 in Public Laws of 2020. The operative language in that law requires credit reporting agencies to treat medical debts as if they were retail credit card type debts, and to report the debts as current, or that the consumer is paying as agreed if the consumer is making regular payments on that medical debt. Soon after the bill became law, Attorney General Fry and I were sued in federal court by Mr. Sultan's clients. I can show you, you too can get your name on federal documents such as this. You don't know what that does to your credit score to be sued in federal court, but not really. But it is part of my job as superintendent is not just to advocate blindly for one side or the other, but rather to lay out the likelihood or the likely result of enacting certain statutes. Because this bill is so close to the one that we are now dealing with in court, and of course I'm completely confident that the First Circuit Court of Appeals will see the state's strong argument and will reverse the lower court here in Maine on appeal. So Charlie and I take different views of the outcome of the pending appeal. But because this is so similar, I think we can expect to see a similar response by CDIA. And I thought you should at least be aware of the likely outcome if the bill is enacted into law.
Thank you, Mr. Superintendent. Representative Matheson, go ahead.
Thank you, Superintendent. If I understand you right, the previous issue that you were put on notice for is still in court, and you don't agree with the assessment of what Mr. Lund said. So even if this did go forward and we did get the same response, you think that Maine has a case here? Am I hearing you right or understanding you correctly?
The Attorney General's office, in consultation with our office, would not have gone forward with the appeal if we hadn't thought there was a good case for appeal. Having said that, my good friend Eric Ellman of CDIA, during our pre-litigation conference last year, did show me the scorecard, and I think CDIA is now 4-0 or 5-0 on these types of challenges, specifically to states across the country who try to do things on behalf of consumers who are facing surprise medical debt. The committee has taken action in this area, and the military law has provided a good format and template to follow, and that is there's no reporting now of medical debt for 180 days. That's designed to allow insurance to kick in and pay the debt if it's appropriate. And under current Maine law, and I don't think that's part of the appeal, under current Maine law, if a medical debt is paid, it does disappear after it's paid or settled from a consumer's report. That's a question earlier from the committee is how far can a state go? I would say that that's certainly on the edge of where a state can go, and I'm proud that Congress decided. Frequently the military law is used to advance certain ideas that are important to consumer credit advocates, such as limiting interest rate or placing caps on interest rates, or in this case, having some impact on medical debt. And so, there has been a lot of attention paid to medical debt in recent years, and I think it is 100% positive. I do believe this one goes beyond the point where CDIA would sit and say that's a good law. We would likely be facing another similar appeal.
Thank you, Superintendent. I see no other hands raised, so I will ask if there's anyone else in our Zoom call who intended to testify verbally on this bill. Please raise your electronic hand at this time. Seeing no hands go up, we are going to bring the hearing on LD 365 to a close. And I'm going to continue to kind of plow through here. The next bill that we will pick up is also from Representative Morris, and it is LD 750, an act to increase transparency of and lower healthcare costs. And I will drop the link to the concept draft language into the chat. And Representative Morris, go ahead.
All right, thank you, Madam Chair. Senator Sanborn, Representative Tepler, distinguished fellow members of the Joint Standing Committee on Health Coverage, Insurance, and Financial Services. My name is Joshua Morris. I represent the people of Turner, Leeds, and Livermore. I'm here today to present LD 750, an act to increase transparency of and lower healthcare costs. This bill builds on the right to shop legislation that was passed in 2017. The most important thing this bill proposes to do is make the law permanent by eliminating the repeal set for January 1st, 2024. Right to shop is good policy. By leaving in the repeal, it disincentivizes insurance companies from offering a comprehensive benefit. They can wait it out another year and a half until it goes away. The next most important thing this bill does is extends right to shop to surgical procedures. The provision makes sense because there is a wide range of costs for surgical procedures. If consumers can find a high quality, lower cost procedure out of network, they should be allowed to shop for it. The bill also requires that insurers offers more savings to their members. The idea behind this is that consumers should be able to shop for services that offer a real benefit and savings to them. It would require that they offer competitive procedures that offer better savings. The bill also extends the right to shop to more health plans, requiring that it be offered by HMOs as well. Regardless of where consumers get their health insurance, consumers should have the benefit of getting lower prices. As with LDs 365 and 751, I worked with Joel Allenbaugh in developing this legislation. He is unavailable today, but has submitted written comments, and I'll be available, and we'll both be available for the work session to answer questions, should you have questions on some of the more technical aspects of this bill. I thank the committee for the consideration of this bill and would be happy to try and answer any questions that we have.
Thank you, Representative Morris. Are there questions for Representative Morris? Representative Tepler.
Thank you, Madam Chair, and thank you for this bill, Representative Morris. Representative Morris, a concern I have and I want to ask you about is the application of this bill to small group policies. My concern that our small group market is, as the superintendent said, circling the drain, and whether this would in fact further threaten that market.
I don't believe it would. I think it would. I think it helps. I mean, the real idea behind it is that it helps consumers, the consumers being able to shop for their plans for these procedures. I think that is the overall goal of it. So I don't really see how this could hurt small group markets. I'm sure we'll hear from some opponents that may have testimony to that effect, but I think the real goal of the legislation is to number one, it's already being done, although I recognize there are different places where right now different parts of the law that currently are exempt, and this looks to expand it to more groups. So I think I understand your point, but I don't believe that it would harm the small group market.
Thank you, Representative Morris. Are there additional questions? I have one. I was wondering, and I think Colleen's going to drop it in our chat as well, but I was wondering if you had opportunity to review the report on our current shopping plans, because that report shows that in 2019, the law that you're expanding upon here was only utilized 115 times by only 82 enrollees out of almost 20,000 who were eligible for these incentives. And what I don't see anywhere in your bill is any effort to increase consumer awareness of the incentives that already exist, and increase utilization of the healthcare cost sort of incentive programs that already exist, and that were passed into law in LD 445 4 years ago. So I guess I'm a little puzzled as to why we would continue to try and beat on this particular technique, since it's just not been working so far.
I would say I would certainly be open to any amendments that would increase the utilization and increase the awareness of it. I would say that. I was not on the committee then, and I understand you were, and you worked very hard on this issue yourself. I am aware of that, Senator. I would say I would refer, Joel has some good information in his testimony about how it is being used by some of the companies, and I think that's part of his concern. Is the way some of the companies are not necessarily trying to realize the benefits, trying to push the benefits to the consumers. And I believe that is part of why I am certainly interested in pursuing eliminating the sunset, because as you know, when you put a sunset on something, it certainly decreases the incentive to want to use it if you know you can just run the clock out. And so hopefully that more people would use this benefit if it were to become permanent.
Okay. Are there additional questions for Representative Morris? All right, seeing none, we will hear from Michael Ciampi. Good afternoon, Dr. Ciampi. You can go ahead. Good afternoon, Dr. Ciampi. You can unmute yourself and go ahead. Dr. Ciampi, we can't hear you yet, so hopefully you are getting the audio situated and you can unmute yourself. All right. We are still not able to hear him. Let's move on to Gwen Simons and we'll circle back to Dr. Ciampi. Good afternoon, Ms. Simons, go ahead.
Good afternoon, Senator Sanborn, Representative Tepler, and members of the committee. I am Gwen Simons. I am representing the main chapter of the American Physical Therapy Association. I'm also a physical therapist myself and a healthcare attorney in Scarborough. We're testifying in support of LD 750. My testimony, written testimony, has been provided along with some letters from out-of-network physical therapists. I think there's about 6 letters from them explaining why they support this bill. And I want to address, I think, a couple of the questions that have come up, specifically yours, Senator Sanborn. Back when we passed this bill, we were proponents of it in 2017. But because of how narrow the scope is and how few consumers can access this law, we found after we passed it that there just weren't very many consumers who really could use it. In the last few years, in my law practice alone, I have helped about 15 therapists start new practices, and in the last 2 years, and out of those 15, only 3 are accepting insurance. So there's a growth in the number of specialty providers in the physical therapy field who are starting new practices and staying out of network with everyone, including main care. And the reason why they're doing that is because, number one, they're tired of the hassles with insurance. The administrative costs are extraordinary if you participate in insurance, and they want to keep their costs down. So the number of providers who patients can access, if we expand the coverage in this bill, is going to be growing. But we've got this main care requirement, and that is a problem. The solo providers who are starting new out of network practices are not participating in main care by choice because they are too small. They can't do the billing. They don't have admin staff, and they want to keep their costs low. So to require them to do something that actually will make them have to shift costs onto the very people that they're trying to keep the costs down for doesn't make sense. So we do believe this bill will serve consumers well if we expand who can access it, and if we get rid of the main care requirement. And we're really not going to know how effective it could be at controlling healthcare costs until we do that. So thank you for your time, and I hope you will read the testimony of the therapists who provided letters. Thanks.
Thank you, Ms. Simons. Are there questions for Ms. Simons? I have one, Ms. Simons. We often talk about access to affordable, high quality care. And if we were to go ahead and take your advice and delete that last sentence there of the current out of network deductible applicability statute, don't we just further incentivize more and more providers to refuse to accept not only main care, but also insurance and Medicare? And then what we're doing is providing one level of healthcare access for the wealthy and another level of offerings for those who rely on main care and Medicaid. Can you speak to that?
Yeah, very good question. So and I know that was a concern when the bill first passed, that providers and specifically therapists would drop out of network. Of the therapists that were already in network, none to my knowledge have dropped out, certainly not because of this bill. And so I don't think that is going to be true. The people who already take insurance are committed to taking insurance. It's where the growth in private practices that is a concern, because more therapists are not going in network in the first place. And the people who are making that choice, they're going to make that choice anyway. And patients are going to pay out of pocket for their services should a patient choose to go to those out of network therapists. So really all that we're doing is expanding the opportunity for those patients who are seeking high quality, low cost out of network therapists to be able to use their healthcare benefits. So I don't know if that answers all of your questions, but I don't think it will impact the in-network, the status of people who are already in network. Did that answer your question?
I think it's fine. I don't think it answers the piece about main care enrollees or Medicare folks who need access to providers, but I think that's okay. We'll let it go.
Okay.
Are there additional questions for Ms. Simons? All right, seeing none. We thank you for bringing the testimony of the other 6 folks as well, and I'll direct committee's attention to the letters that were attached to your testimony and appreciate those being submitted. And next I see Dr. Champy, so I think that's a good sign. So we will go to you, sir. Please unmute yourself and go ahead.
Thank you, Senator Sanborn. I apologize for tardiness. I was between patients, but I appreciate the opportunity to testify. I wasn't sure if I was going to be able to, so I did submit written testimony as well, and I encourage you to refer to that. My name is Michael Champy, MD. I'm a family physician living and working in South Portland. I'm the owner of Champy Family Practice. I am also president-elect of the New England Direct Primary Care Alliance, as well as a healthcare policy advisor for the Heartland Institute. But today I'm speaking solely as a concerned citizen. I had the privilege of testifying before this committee in 2017 in favor of the right to shop bill. And as I understand, the LD 750 is proposing amendments to said what is now a public law. What my concerns with how the right to shop bill was implemented that necessitates amendments are a few key points to bring up. First of all, the way that the law was implemented by the insurance companies has not allowed the intended goal of the legislation to come to fruition. Basically, the law was intended to allow patients to have transparent data and to be able to shop for quality healthcare services, whether in or out of network. And if they found equal quality services for a lower price, they were supposed to be able to share the cost savings with the insurance company. Unfortunately, what has happened is, for one reason or another, the insurers don't appear to be on board with this and are not making the process very easy, very transparent, and frankly, the opportunity to have the consumers save money and benefit from these cost savings have been quite anemic. I think one insurer will give you a $5 gift card if you save them thousands of dollars on blood work or an MRI. It's really not worth the consumer's time to do the work to save money if they're not rewarded for it. So I would support the amendments to mandate that the insurance companies share more of the cost savings with the consumers doing the work. This is all about making healthcare more affordable, and unfortunately, this has been a roadblock to making that happen. Also, I would encourage the committee to consider expanding the program, not to just HSA eligible health plans, which are by definition high deductible. I think all healthcare consumers in Maine should be able to benefit from this law, not just people with high deductible plans. And furthermore, I would like to see this plan expanded to not just laboratory and radiology services, but to procedures, doctor visits, surgeries, physical therapy visits, et cetera. I think there's a lot of opportunity to save Mainers money, but I think the program as it stands now is far too restrictive. And finally, I would also encourage the committee to consider not letting this law sunset. I have a feeling that the insurance companies are just biding their time, trying to run out the clock until this law goes away. And I really think it needs to be established permanently and have a little bit more teeth to hold the insurance companies to account. So.
Thank you, Dr. Champy. Are there questions for Dr. Champy? All right, seeing none, we thank you for joining us, and sorry we caught you at a moment when you weren't available. I'm glad we were able to hear from you.
Appreciate it. Thank you very much.
I will next ask if there's anyone else in the meeting who wishes to testify in favor of the bill. Seeing no electronic hands go up, I will turn to those testifying in opposition to the bill, and first we'll hear from Jeff Austin.
Senator Sanborn, Representative Tepler, members of the committee. My name is Jeff Austin here on behalf of the Maine Hospital Association. Can you hear me? Yep.
Yes.
We're here to oppose the bill, and I appreciate you accepting our comments. First, just to get this out of the way, the bill 4 years ago or whenever it passed did not create a right to shop. The right to shop exists regardless of this bill or the underlying statute. Consumers have the right to choose their healthcare provider under federal and state law. So you have the right to shop, that exists. What the bill attempts to do is create a state manufactured incentive to shop. And we oppose the state manufacturing incentives to shop solely on the basis of price. We don't oppose people shopping. Individuals, if they want to shop, so be it. We wouldn't run legislation to oppose that. If employers want to create incentives for their employees to shop, we wouldn't run bills to stop that. If carriers want to create incentives to shop, and they do, we don't oppose that. What we do oppose is the state doing this. You ask us to do things that make us less competitive on price. Is it purely the state's fault that we're less competitive on price? Obviously not. But things like charity care, which we heard about yesterday, require us to try to shift some costs onto commercial rates. Low Medicaid reimbursement requires us to raise our commercial rates. If you don't believe me, read the testimony from all the physical therapists in favor of this bill. They uniformly said, if I had to participate in main care and accept those low rates, we would have to raise our commercial rates and become less competitive on price. Exactly. You want us to be there for your main care members. So since you want us to do those things that make us less competitive on price, we ask you not to pass laws inserting yourself into the market and creating artificial incentives to people, for people to not consume our services. So with that, I'd be happy to take any questions, but we do oppose this legislation in its entirety. Thank you.
Thank you, Mr. Austin. Representative Tepler.
Thank you, Madam Chair. And Mr. Austin, I don't really have a question for you, but I am disturbed by your attitude about main care members. They're our main care members. I am concerned that we are not expressing the correct attitude towards the fellow citizens of our state who may be in need of some financial assistance in order to be able to afford health care. And I ask you if your attitude reflects that.
I think what I meant to say was they are your insureds. You run an insurance company. So we call Anthem patients. We call Medicare patients. You run the main care patient program, so they are your insureds. You set the parameters of reimbursement. That's what I meant by yours. It's your program. So I accept the comment, but I mean to say you run the program. It is your program, and it is your reimbursement rates that the PTs have testified make providers who participate in your program less price competitive.
It is a federal program, although we do set some of the rules in the state of Maine. But I'm just, the attitude I'm hearing from you, Mr. Austin, concerns me. Thank you.
Okay. Are there additional questions for Mr. Austin? All right, seeing none, thanks for testifying. And next we'll hear from Chris Ossenfort. Good afternoon, Ms. Ossenfort, go ahead.
Good afternoon, Senator Sanborn, Representative Tepler, members of the Health Coverage Insurance and Financial Services Committee. My name is Christine Ossenfort. I'm the Director of Government Relations for Anthem Blue Cross and Blue Shield in South Portland, and I appear before you this afternoon to testify in opposition to LD 750. I would note at the outset that Anthem already offers our right to shop incentive on all of our small group plans. It is not limited to our HSA plans. Nonetheless, we have seen very little take up, as the committee is aware from the Bureau of Insurance report. And this is actually consistent with our experience in New Hampshire at the time the legislation was introduced, where we were already offering a version of the Smart Shopper program, which is our right to shop incentive program. We do have concerns with the requirement to pay a minimum of 25% of the savings. That a similar provision was actually included in the original legislation as it was introduced in the 128th, I think. And it was removed from the legislation because it's difficult to operationalize, because that number can vary as that language is drafted. And the current language was included in lieu of that requirement because it created more flexibility and ease of administration. And the easier it is to administer and promote, the more likely it is that members would take advantage of it. With respect to Section 2, as Mr. Austin touched upon, and I think Senator Sanborn may recall, my recollection is consistent with Mr. Austin's, that requirement of participation in main care and Medicare was to guard against providers being able to offer lower rates because they did not experience the cost shift associated with participating in those programs. And I would say that if this were working, we would be supporting a repeal of the sunset provision. And elimination of the sunset doesn't mean that carriers can't continue to offer these programs. It just means that we would have more flexibility and be able to offer them in perhaps alternative fashions that might be more attractive to members. So with that, I would be happy to answer any questions that you may have, and will of course participate in your work session as well.
Thank you, Ms. Ossenfort. I noted in your written, actually I noted in Ms. Palatro's written testimony. Never mind, I will ask Ms. Palatro about it. I'm in the wrong piece of testimony. I apologize. The dangers of
I didn't think I had finished writing it.
Okay, never mind. Thank you. Thanks for being here. Are there any other questions for Ms. Ossenfort that are actually for Ms. Ossenfort? Representative Quinn. You're on mute.
Seems no matter how many times I touch it, I'm still muting myself. So thank you very much. I'm just wondering, if this were repealed, what sort of alternatives would you be speaking of in regards to this?
It's hard to say right now because we're in sort of a state of flux with facing the clear choice plan design requirements and the merger of the market and the requirement to offer, the same plans in individuals to small groups. I'm not sure that if this were repealed that we would stop offering the Smart Shopper program, but our experience has been that it's more effective with large groups and with small groups. And I'm not sure that we really can point to a particular factor for that other than large groups tend to have HR departments who may be more proactive in making employees aware of these types of programs. But I think we would certainly, I can take that back and see if we have any suggestions for your work session.
Thank you, Ms. Ossenfort.
Thank you.
Do you have a follow-up, Representative Quinn? Okay.
Well,
I did
have one, because I think it's great that she brought up that a lot of times larger employers might let people know. To be honest, before all of this and being part of the legislature, I did not know that this actually existed. And I think that's the case with a lot of people in my community. And if they did know about it, I think that they would actually be a little more proactive. So I just wanted to throw that out there. Thank you.
Thank you. It is a challenging thing. We do push it out. It's mentioned in our certificates. We have brochures that we provide, but it's tough to sort of break through sometimes.
Perhaps we can take an informal poll as to whether anyone who has the legislators insurance knows how many incentives are actually available for us legislators. I try to use them all the time, but they're very difficult to use. They're very difficult to find. And it just adds another hurdle. So, all right. Are there any other questions for Ms. Ossenfort? All right, seeing none, we will move on to Ms. Palatro. I do actually know the difference between Ms. Ossenfort and Ms. Palatro. Just had a momentary lapse there. Good afternoon, Ms. Palatro.
Senator Sanborn, Representative Tepler, members of the committee, my name is Catherine Pelletreau. I'm the Executive Director of the Maine Association of Health Plans, and I'm here to speak in opposition to this bill. You've heard a little bit about the Bureau's report and the fact that the uptake on these programs has been quite low. What I want to spend my time talking about is really how the whole environment around shopping for care is shifting and becoming dramatically more robust. You've heard some testimony on other bills about some of the transparency law that's recently been passed at the federal level. And I wanted to tell you a little bit about what is in that law and who it applies to. So it's actually, in my testimony, it calls it a rule. A rule has the power of law, but it requires disclosure of negotiated rates. That's very new. And a lot of patient cost calculator detail. So by on or after January 1st of 2023, carriers must have online cost calculators that include 500 shoppable services. So a dramatically higher number than the right to shop law in Maine. And I'm a little hesitant, but I think it actually might be close to or more than what's even on Compare Maine right now. I think Compare Maine has like 365, something like that. And then further, by January 1st, 2024, that same cost calculator must be available for all covered items and services. This includes prescription drugs, includes durable medical equipment. The requirements are really detailed. They have to be based on in-network rates, out-of-network allowed amounts, and personalized with an individual's accumulator. So, where they are on their deductible. They have to be accurate at the time of the request, but there is some flexibility about what might happen during somebody's procedure or interaction, around a particular service. So they don't necessarily reflect the final cost. And the amount has to be presented in dollars as opposed to a percentage. And give a range of what a individual patient might expect to pay for a particular procedure. So that's in a nutshell what's required and coming down the pike very, very rapidly. The other point to make is that these regulations are going to apply a lot more broadly than Maine's right to shop law. So they include fully insured group health plans, self-insured group health plans, individual market, ACOs and capitated payment arrangements, HMOs. Really the only commercially insured benefit plans that are exempt from the final rule are things like healthcare sharing ministries, short-term STLDI, I'm not going to quite get it right, but it's the short-term policies. So not typical major medical insurance. So this, as I said, goes way beyond the Maine's right to shop law and expands it to pretty much the entire commercial population and every service, including pharmacy, by 2025. So it changes the relevance of Maine's right to shop law, and given its slow uptake, we really think that it's not necessary to pass this law, or to pass the proposal in front of you. Thank you.
Thank you, Ms. Palatrow. Representative Tepler.
Thank you, Madam Chair. So if we don't pass this law, beginning January 1, 2023, the law that we have that extends through 2024 is essentially preempted by federal law anyway. Is that correct?
I don't think it would be preempted. Maybe they would have to run simultaneously, but speaking very frankly, and you've heard testimony about this before, how much motivation do you think you're going to see to develop new programs in 1 year when this huge federal initiative is right in front of them?
Makes sense. Thank you.
Representative Arford.
Yep, thank you, Madam Chair, and thank you, Ms. Palatrow, for being with us. I'm going to state the obvious in that I thought this when we heard the earlier bills. Would it not make sense? I'm wondering from your perspective, representing the carriers, if Maine was going to initiate new legislation, might it not make sense to simply mirror what the federal government is going to be doing very soon anyhow?
That I think that's better than continuing a kind of separate and distinct state-specific track.
Ms. Palatrow, I want to ask a slightly different question, or I want to sort of parse this a little bit of a different way. There's actually two pieces to the bill that's in front of us and to the right to shop bill that we that I worked so hard on in 2017 with Senator Whittemore. One piece of it is this requirement that plans offer incentives for certain limited quote unquote shoppable care. The other piece is really perhaps more powerful and very, very different, which is that if you go to an out of network provider and you're still under your deductible, but you're paying out of pocket to a provider who's actually less expensive than if you were going to an in-network provider, those payments that you make have to count towards your deductible if you send in the form and ask them to be counted. I'm wondering if you could reflect, is your testimony really just about the first part of that two-part discussion or two-part bill that I really just talked about there? Because it doesn't strike me that anything you just mentioned is actually relevant to this question about deductible counting.
Mm-hmm. I'd offer one comment. First, say yes, we did focus primarily on the first part. The other thing that I did hear from our members that was not included in my testimony is some of the challenge with kind of creating new plans. You know, Christine Ossenfort had mentioned, how is this going to work with Clear Choice and the limited plans that are going to be available now? And I would just say under right to shop, I mean, plans have to develop what their incentives are going to be and build a plan around that and build a system around that that handles, you know, the issues that you're raising, the cost sharing, et cetera. And that's been challenging. So I'll just stop there.
Okay, thank you. Representative Arford, is that a residual hand? Okay, great. All right. Seeing no further questions for Ms. Pelletreau, we've reached the end of the list of folks who had registered in advance to testify on this bill. If you wish to be heard verbally on this bill, please raise your electronic hand at this time. Okay, right. It is 1:07 and I am late to my date with the Judiciary Committee to present on one of the bills we passed out of this committee. And so I need to turn over the gavel to Representative Tepler, or we need to have lunch now. I guess we could have lunch now, or we could finish this next bill. Representative Matheson is asking if we should finish the next bill, is nodding that we should finish the next bill. So let's finish the next bill. We will still have two bills to do after lunch, but I think that probably makes sense. Representative Tepler, do you want to take it away?
I certainly can. Thank you, Madam Chair.
Okay,
and,
I'll be back as soon as I can.
Presenting to Judiciary. All right, so with that, I will open a public hearing on LD 751. And I believe this is also sponsored by Representative Morris. So I'm going to ask him to go ahead and present the bill to us.
Yes, thank you, Representative Tepler. Senator Sanborn, Representative Tepler, distinguished fellow members of the Joint Standing Committee on Health Coverage, Insurance, and Financial Services. My name is Joshua Morris. I represent the people of Turner, Leeds, and Livermore, here today to present LD 751, an act to allow employers to shop for competitive health care options. In a competitive job market, employers want to offer the best compensation package they can. This is not only through competitive wages, but also through a strong benefits package. The bill seeks to allow employers to find the best health insurance options for their employees by allowing insurance companies to have better information around claims experience. Currently, the only number insureds are required to give is the loss ratio on claims. For example, if you spend $100,000 on premiums and $90,000 on benefits, that is all that your insurer will report to another insurer you may want a quote from. This bill would require the incumbent insurer to disclose more in-depth information about the claims experience. If a company has some high-cost claimants, that will impact their claims experience, for example. This bill would allow the incumbent insurer through their underwriter to disclose to a potential new insurer any information relating to these claims. All the information would be depersonalized and only sent between insurance companies. to comply with state and federal laws around medical privacy. The bill will also help employers to be able to shop for competitive health insurance plans. It will enable them to find better prices that will benefit their employees. If there is a savings, they can use the money to reinvest in their business, either through a better benefit, higher wages, or other parts of their business that improve the experience for both their customers as well as their employees. As with LDs 365 and 750, I've worked on this bill with Joel Allenbaugh. I refer the committee to his written testimony for some of the more technical questions you may have on this. He will be available for the work session to answer any of those technical issues. I will be happy to answer any of the questions that I can today.
Thank you, Representative Morris. Are there any questions for the sponsor from the committee? Seeing none, I will turn to others who might like to testify in favor of the bill. And I see we have, is Ms. Cook in the queue?
Yep.
Okay, let's hear from Ms. Kimberly Cook.
Good afternoon, Representative Tepler and members of the committee. I'm Kim Cook, and I'm here on behalf of Community Health Options in support of LD 751. As you all are familiar, Community Health Options is Maine's only nonprofit co-op health insurance company. We are based in Lewiston and provide health insurance in the individual, small group, and large group markets, as well as providing health plan administration for self-funded plans through our Pioneer ASO. Health Options exists for the benefit of our members and our mission, which is to provide affordable, high-quality benefits that promote health and well-being. We support this bill as consistency in the underlying data elements available to large employers will support a better functioning large group market. This bill is an important step forward for large employer groups to shop for and secure the most competitive coverage for themselves and their employees. Currently, it's difficult for a large employer to shop for comparable coverage because the information that they need is not always available from their existing insurance carrier. We would suggest that the committee consider a couple of the details of the bill as whether what the right levels to be set in the bill are, and so I'll give you a couple of examples for your consideration for possible amendments. Regarding the level of aggregate claims for which diagnosis and prognosis information must be provided, we would suggest that the committee consider establishing a sliding scale based on the size of the group. One option, for instance, for your consideration would be to use a sliding scale whereby the larger the group size, the higher the reporting level. And let me see if I can give you an example, because if you would kind of, well, let me just give you an example and see if that helps explain what I'm trying to say. And we will be submitting written testimony as well. For employer groups of employees of 51 to 100 employees, you could set the level at $25,000 per member. Under the current bill, it's $20,000. And then for groups at 101 to 250 employees, you could set the level of claims exceeding $50,000 per member, et cetera, and then you could go up from there. So you'll see that information in our testimony for your consideration. The other thing we wanted you to consider is that based on our analysis of the bill, our team felt that it would be difficult to obtain some information that's required for reporting by the plans, such as hospital stay, pre-certification data, and data regarding prognosis. At least for us, that would require manual data pulls and be staff intensive. And so if you were willing to either remove those or think about how, whether that's a necessary piece here, we would appreciate that. But overall, we think the concept in the bill would be a positive for the large group market. And I'm happy to answer any questions you might have.
Thank you, Ms. Cook. Any questions from the committee for Ms. Cook? Ms. Cook, I have one. I'm a little confused by the interaction of this bill with the operation of Megara, the reinsurance group that helps to protect insurance companies currently against high cost claims. So I guess I don't quite understand how this interacts with Megara.
I don't believe there'd be any interaction between this and Megara. Megara right now serves to help reduce premiums essentially on the individual market. It could potentially be expanded to the small group market with some of the changes that are being recommended by the legislature and the superintendent. That's under active consideration. But it's not impacting premiums as I understand it on the large group market. And so that I did not expect that I would be called first, especially on this bill. We did not bring this one forward, but and I signed up late even. My apologies for that. But you know, with the small group and the individual markets, they're community rated. With the large group market, it's experience rated. And so that's why this type of information is critical for large employers in order to shop, where it's not something you would need for individual coverage or if you're in a small group coverage. And so when a large group and others, I'm sure there's got to be others here to support it, go to shop, then the carrier says, well, we need some of your experience to be able to give you a quote. And they say, okay, I can ask my existing carrier to see if they could provide it. And I think this bill is intending to ensure that any large employer has access to that information so that they can make sure that they're able to shop and get the best deal for themselves and their employees.
Thank you. I do understand now. I don't know why I missed
the
large group piece. Thank you. Representative Evans, do you have a question for Ms. Cook?
Thank you, Madam Chair. I was just looking at it. It says, it seems like my interpretation, the small group market is excluded.
Yes, that's my understanding of the bill as it's written.
Okay,
in section 4, with the exceptions. Yeah.
Yes, I made an error, Representative Evans. Are there any other questions from the committee for Ms. Cook? Seeing none, thank you for your testimony, Ms. Cook.
Thank you.
Is there anyone else in the attendee list who would like to testify in favor of the bill? Seeing no electronic hands raised, I will move on to those who might want to testify in opposition to the bill. Is there anyone in the attendee list who wishes to testify in opposition to the bill? Seeing none, we will move on to those testifying neither for nor against. And first up, we'll turn to Mr. Butterfield from the Leukemia and Lymphoma Society. Mr. Butterfield?
Good morning. Afternoon.
Afternoon now, yes.
My brain was still stuck in the schedule, sorry. Good morning, Senator Sanborn, Representative Tepler, members of the committee. My name is Steve Butterfield. I'm a Regional Government Affairs Director for the Leukemia and Lymphoma Society. I will tell you right now, it's likely that we will be submitting written testimony that will move us further into opposition than neither for nor against. But given that we just saw the language on this bill very recently over a holiday weekend, right now, I would say what I have are some questions and concerns more than a firm position. Our primary concern relates to privacy. The way that we read this amendment as drafted, despite the fact that the bill says that information provided under the amendment here would be de-identified, it's also asking for a level of specificity and individuality in claims data that would make it either trivial or insignificant for an employer or an insurer to identify individuals based on the information that they're being asked to provide on those claims. I appreciate Representative Morris in his introduction saying that the intent is for this to go exclusively from insurer to insurer, because I am also concerned in section 1, it does say that this could be provided to a group policyholder or employer for the extent of reporting loss information. And the concern there is simply that a patient should be the one who decides whether or not and in what venue and how to disclose a health condition to their employer or not disclose that health condition to their employer. Obviously, I represent blood cancer patients through the Leukemia and Lymphoma Society, but there are any number of conditions that popped into my head reading this where an individual may have very good reason not to want this level of detail, their health utilization disclosed. So privacy is the first concern. The second concern that we have is that in the large group market, there's a lot more latitude and flexibility offered to purchasers in terms of designing their plan. Whereas in the individual or small group market, you sort of pick from a menu of pre-designed plans. Large group carriers or large group purchasers can make a lot more decisions about the structure of the benefit design that their plan will have moving forward. The concern being, if you were able to see that a particularly expensive category of conditions, was prevalent or existed among your employee pool, our concern would be that this would open the door to potentially creating or incentivizing the design or purchase of large group plans that are going to put more expense or diminish first dollar coverage for certain conditions that employees have. If you saw, for example, that you have several employees who spend, tens of thousands of dollars on claims for, Butterfield syndrome, I'll make up a disease here. It could create a really unfortunate incentive where you would move treatments for that condition to more expensive categories of your plan benefit design, which we have significant concerns over. Would there potentially be other avenues for somebody to object to, a change in the design like that? Maybe, but why open the door to it? I mean, we're talking about changing the law here to allow this level of reporting where it isn't allowed currently, and we're afraid that raises some red flags as far as the potential for that kind of abuse. So I'm sorry that I'm not coming with more detailed information than just a series of questions. As a former legislator, I appreciate that that's not necessarily always the most productive use of time, but those are the things that are in our mind, and we do plan to expand on this testimony in written form in the days ahead. So I am happy to answer any questions.
Thank you, Mr. Butterfield. And now I'm going to turn to Senator Sanborn, who has a question for you.
Thank you, Madam Chair. Nice to see you, Mr. Butterfield. My question is, my understanding is that already today in the large group market, if your current insurer reviews your losses and your claims data, which they can certainly do in the large group market, they do it every year, and determines that Butterfield syndrome is a thing, amongst your employees or whatever, then they can suggest plan design changes, or they can certainly rate you on that issue. And the problem I think that this bill is trying to solve is that you wouldn't be able to then share or be assured of being able to get that same level of claims detail over to a competitor to perhaps have some other alternatives or a better price that you could compare against whatever your current insurer or third-party administrator is suggesting to deal with particular claims and losses that you had in the prior year. So I'm wondering if perhaps, given the current status quo, which is that in the large group market, you absolutely are looking at the individual claims experience of individual employees, though they be de-identified. This doesn't actually, wouldn't this bill be intended to increase or enhance the competitiveness and the ability for the employer to provide coverage to their employees either at a lower cost or at a better coverage level, rather than the opposite, which is what your questions in your testimony suggested.
Yeah, it's a great question. And I'm just going to say right up front, I don't know the answer to that. And part of that is because I have a lot less experience with large group coverage than with other sectors. Typically states don't have a lot of latitude or authority over large group regulation, and working in state government affairs, it doesn't come up that much. It's an excellent point, and I don't have a solid answer for you right now. So
okay,
I've taken notes.
Thank you very much. And thank you, Senator Sanborn, for your question. And let us turn now to Ms. Ossenfort testifying neither for nor against. Welcome, Ms. Ossenfort.
Thank you, Representative Tepler, Senator Sanborn, and members of the Health Coverage Insurance and Financial Services Committee. My name is Christine Ossenfort. I'm the Director of Government Relations for Anthem Blue Cross and Blue Shield in South Portland, and I appear before you this afternoon to testify neither for nor against LD 751. We do, like as Ms. Cook stated, we too support the idea of standardizing the information that must be provided. Different carriers approach it differently, provide different information. So we are supportive of the concept underlying the bill. We do not have any concerns with respect to expanding it from 12 months to 24 months of data. We support the concept of including pharmacy data, but believe that the language needs to be clarified somewhat to reflect that it is aggregated medical claims by month and aggregated pharmacy claims by month, as opposed to, I believe it said individual or separately. So we want to make sure it's not requiring transmission of each individual claim, but rather the total medical claims in a month and the total pharmacy claims in a month. It's also not possible to really create separate loss ratios for medical claims and for pharmacy claims because it's one premium. So we would suggest that the bill be amended to require reporting of medical claims by month, pharmacy claims by month, and then the loss ratio for the total claims for each month. We also support the concept of including high cost claimant data, but do have some concerns with the bill as it's drafted. We would suggest that the threshold be $50,000 rather than $25,000, which $50,000 tends to be considered the industry standard. We are opposed to the requirement to include information about prognosis as well as pre-certification. We don't really have prognosis information. We have diagnosis information, but not prognosis. Pre-certification, as Ms. Cook noted, to provide that information would be an extremely manual process. We are also concerned that with respect to smaller groups, it might be easy to identify who the high cost claimant is. So we suggest that high cost claimant data be excluded or not required for groups with less than 25 enrollees. We would note that the bill authorizes transmittal of information to the employer, and it would require that the carrier, forgive me as I've lost the language, it would require that we cannot transmit the data to any group policyholder that is not in compliance with the paragraph. We really have no way to know if the employer is complying with the requirements of HIPAA. So we would suggest that that instead be phrased to say that we cannot provide the information unless the group policy holder has certified to us that they are compliant with HIPAA. And then finally, it does make a slight change. Small groups are currently excluded from these requirements. The bill changes it to say that it would be small groups who are going to renew in the community rated market would be excluded. There's no way for us to know whether somebody will renew in the community rated market or not. So we would suggest that that exemption be retained as it exists today. So with that, I'd be happy to answer any questions that you might have, and I'll be present at your work session as well.
Thank you, Ms. Ossenfort. And I do hope you will submit all those comments in writings for us to take a look at.
I will. I apologize. It's a busy time for you all right now.
Tell us about it. Yes. And Senator Sanborn has a question for you. Go ahead, Senator Sanborn.
I do. Ms. Ossenfort, I had the strange experience of having just tried to fill out a form that Anthem asked me to fill out related to obtaining a quote for health insurance. And it asked me to list all high dollar claimants among my employees who had claims more than $10,000. So I'm a little bit disturbed by your testimony because Anthem has a form itself that it hands out when folks are looking to get bids. This is in the small group employee benefit excess insurance market, which or level premium or level funded plan market, which Anthem is now offering coverage in. And I'm just a little like, I'm kind of shaking my head because you guys have a form that asks for information, which you are suggesting we should not require you to provide.
I will take that back. It was suggested to me that 50,000 is the industry standard, so I will go back and ask for more additional information. Thank you, Senator.
Thanks. Yeah, 10,000 seemed very low to me. It would be, you know, one broken ankle gets you over $10,000 these days. So I would certainly hope you guys would reconsider that form at least.
Thank you. I'll take that back.
Okay.
Right. Any other questions for Ms. Ossenfort from the committee? Seeing none, thank you for your testimony, and I will call Ms. Pelletreau to testify, neither for nor against LD 751. Welcome again, Ms. Pelletreau.
Good afternoon, Senator Sanborn, Representative Tepler, members of the committee. My name's Catherine Pelletreau. I'm speaking for the Maine Association of Health Plans, neither for nor against. I'm not going to go through my whole testimony. You've heard it, quite a bit of it from others. I will just point out that this was an interesting one for our association that, it was kind of a competitive issue. As we dug into the details of the bill, it became clear that there were some plans that favored it more than others. But there was universal agreement around a few key things that I've tried to pull out in the testimony. I think chief among them is the privacy consideration, but also the level of detail of information that's being asked for, the matter of monthly reporting on loss ratios. The suggestion is made that that be quarterly, which should be sufficient to give a trend without burdening with, really what our folks thought was excessive reporting. I got the same feedback that Chris had gotten, that 50,000 was a better number, that 20,000 was too low because it could easily be met by an outpatient procedure that would not have a lasting effect on the cost to the plan over time. Yeah, prognosis you've heard about. It's not something that a health plan would have. I mean, they might have they'd have probably diagnosis, but they're not going to have prognosis. That's a clinical information. And the pre-certification request, just there was privacy concerns around that. There were burdensome concerns around that. Yeah, and that's not something that I guess they would typically provide, is what I heard. So I'll stop there, and I appreciate Senator Sanborn's question for Ms. Ossenfort, and I'm curious about that with the other plans as well.
Thank you, Ms. Pelletreau. Any questions from the committee for Ms. Pelletreau? Seeing none, we very much appreciate your testimony, and we will call an end to testimony on LD 751 unless anyone else in the queue wishes to testify on the bill. And seeing no little electronic hands raised, we will consider the hearing over. And I believe it's time for our lunch break. I'm going to consult Senator Sanborn about how long that break should be, because we will probably have to, well, we don't need to caucus today with that, do we?
We have work sessions this afternoon after the next two hearings.
Yes, okay, that I forget that doesn't show up on my.
It doesn't show up on the list you're looking at, so.
Yeah, so let's take an hour or 55 minutes, I guess I would say, and be back at 2:30. Representative Morris, do you have an announcement you want to make regarding your team?
Yeah, we'll caucus at 2 o'clock. I'll send the link out around then.
Okay, and the Democrats will caucus in our caucus room in about
1:45.
Yeah, 1:45.
Yeah, great. Thanks.
See you there, gang.
Wonder why I did that. I felt like it. They haven't got to their 11:30 yet.
This happened one day last week.
When I saw 5 public hearings in a half an hour, we'll still be doing those public hearings, the other 2 before you get back.
That's a thought. Well, the list is actually super short for them both.
Oh, good.
So the list was short for all of them.
Yeah, all of them, and it only took them.
Yeah.
And they're going to caucus.
Yeah, they are. Their caucuses are usually pretty quick in and out, which I'm always surprised by. I brought you these. You don't even have to do like where they're from or anything, but I do like to know just the order of people testifying. Just because I've done it so far, I feel like I might as well keep going. But that's all I have. And let Colleen know that you're on the call. And
Okay. Good afternoon, everyone. It is 2:32. And we'll try and stay on time as we do have a couple more public hearings to get through today. 1, 2, 3, 4, 5, 6. Representative Evans, are you here?
Yes.
Okay, great.
Sorry.
Okay, hold on just a moment while I get organized here. So this afternoon, we do have 2 public hearings left to get through. And the first is LD 1450, an act to provide fairness in communications from pharmacy benefit managers, presented by my co-chair, Representative Tepler. So Representative Tepler, go ahead. You're on mute still. And before you get started, I'll just ask the attendees to put their hands down as we're just starting the public hearing, and I will go ahead and give further instructions as we move forward. Thanks. All right. Go ahead, Representative Tepler.
Thank you, Madam Chair, and Senator Sanborn. Fabulous colleagues of the Health Coverage Insurance and Financial Services Committee. I am Denise Tepler, representing all of the town of Topsom, House District number 54. And today I am presenting LD 1450, an act to provide fairness in communications from pharmacy benefit managers. Independent pharmacists are facing a difficult situation with a variety of anti-competitive efforts from large chain pharmacies, especially those that are vertically integrated with pharmacy benefits managers and insurance companies. Communications to consumers from pharmacy benefit managers imply that their local pharmacy may not be in network when it is, or letters give the impression that if they switch to the integrated pharmacy, their medications will be less expensive. I recently encountered one of these letters myself. Express Scripts, our state health plan's PBM, sent me a letter regarding one of my medications and indicating that I should switch to their mail order pharmacy. Concerned that they might no longer cover my medicine at my regular pharmacy, I called them. No, the issue was that I could get a 90-day supply from them. But I'm getting 90 days now for a $45 copay. Would that change? Apparently no, but the medication would be mailed to my door. However, if I made the switch in June when the state changes contracts, I might have to get a new prescription from my physician, as Express Scripts will no longer be the state's plan's PBM. This kind of anti-competitive communication with consumers is an increasing problem for our Main Street pharmacies. This committee can help find a solution. Thank you for all your hard work on these tough issues. I will attempt to answer any questions you have, but there are those testifying after me who are better equipped to provide clarity on this issue.
Great, thanks, Representative Tepler. And again, I'm on the wrong page as usual. Okay. So next we will hear from Ron Lanton. Mr. Lanton can join us through the wormhole. And I'll just let attendees know that I do have a list of folks registered to testify, and that's generally how we go about it in this particular committee, is that I'll go down through my list of those who had registered to testify. And then if you didn't get a chance to register, I'll give you a chance to raise your hand at that point. Mr. Lanton, go ahead.
Well, thank you very much, Senator Sanborn, and thank you, Representative Tepler, for your introduction. We very much appreciate it. I do know that there may be some pharmacies here as well. I know that a lot of them today are in vaccine clinics. So if they aren't here, they will definitely be submitting testimony. And I know that I'm going to be followed by the National Association of Community Pharmacy. That's the national group that represents the pharmacists, the independent pharmacists. So thank you very much. I'm not going to say too much because I know you guys are probably tired from such a long day that you've had today. But basically, this bill is very short and sweet. I think Representative Tepler nailed one of the common examples that our pharmacies have been seeing. A lot of times beneficiaries will come back to their pharmacy saying, I got this letter from, CVS Caremark, and it kind of indicates that maybe I have to I can't use your pharmacy anymore. I have to go to this one. And, as usual, when we come before you guys, we're not asking to pick winners and losers. We've never done that. All we're asking for is some clarity and just to maybe level the playing field with this. We definitely have a problem with these guys sending letters out and not really providing any accurate or fair information about who's in the network or whether a consumer has a choice. And of course, Maine has an any willing provider statute if the consumer wants to use, Joe's Independent Pharmacy or Rite Aid, they can do that. But these letters do cause confusion. So we're just asking for a way to figure out how do we not cause confusion anymore. We don't really care if it's with the bill, if it's with bulletin, we just need some kind of resolution. So with that in mind, I will be happy to answer any questions. And I'm also very curious to see what those behind me that are in support of this bill have to say.
Thank you, Mr. Lanton. Are there questions for Mr. Lanton? Okay, seeing none. We will next hear from Matthew Magner. Good afternoon, Mr. Magner. You can go ahead. Good afternoon, Mr. Magner. You can go ahead. You're currently on mute, so we can't hear you.
Okay.
There you are. Go ahead.
Thank you. Chair Sanborn and members of the committee, thank you for giving me the opportunity to provide testimony on behalf of the National Community Pharmacists Association in support of LD 1450. We believe this bill will give Maine patients greater authority over their healthcare decisions by protecting them from misleading PBM communications. Just some background, as you had heard from Mr. Lanton, NCPA represents the interests of America's community pharmacists, including the owners of more than 21,000 independent community pharmacies across the United States and 54 independent community pharmacies in Maine. Misleading communications from PBMs can usurp a patient's authority to make his or her own healthcare decisions by leading patients to believe they must utilize a PBM-owned pharmacy, often a mail-order pharmacy. When this happens, the patient is forced to make healthcare decisions based on the PBM's bottom line instead of the patient's health. Under this bill, a PBM would be prohibited from providing customers information that only mentions the PBM's affiliated pharmacies. This provision will help ensure patients have more information to make decisions that are in the patient's best interest instead of what's in the PBM's best interest. For these reasons, I respectfully request your support of LD 1450. I thank you for giving me the opportunity to talk about this bill, and I'd be happy to answer any questions you may have.
Thank you, Mr. Magner. Are there questions for Mr. Magner? All right, seeing none, I will ask if there is anyone who is in the Zoom meeting who wishes to testify in favor of the bill. Seeing none, I will ask if there's anyone. Oh, I do have two people signed up to testify in opposition to the bill. So first we'll hear from Sam Hallmeyer. Good afternoon, Mr. Hallmeyer. Go ahead.
Thank you, Madam Chair. Thank you for allowing me to speak today. Thank you, Madam Chair Sanborn, members of the committee. My name is Sam Hallmeyer, and I'm here on behalf of the Pharmaceutical Care Management Association, otherwise known as PCMA. Thank you for allowing me to speak today and give comments opposing LD 1450 along the lines of pharmacy communications. Again, PCMA is the National Trade Association representing America's pharmacy benefit managers, otherwise known as PBMs. PBMs administer prescription drug plans for millions of Americans with health coverage provided through their large and small employers, health plans, labor unions, state and federal employee benefit plans, and government programs. I appreciate that. Again, I appreciate the opportunity to speak today on LD 1450 around pharmacy communications. I did submit written testimony on this, but real quick, I want to highlight some of the key points. Health plans, they design networks of pharmacies that include independent pharmacies, chain pharmacies, mail orders, and specialty pharmacies to provide patients with a wide access to a range of high quality pharmacies while also saving costs. These networks include both affiliate and non-affiliate pharmacies, and members are notified of this list on their PBM's website under the explanation of benefits in the directory. Again, to balance savings and patients for patients and payers, PBMs require pharmacies to compete on service, price, convenience, and quality to be included on certain preferred networks. If the intent of this bill is to create a more equitable level of pharmacy advertisement, again, the list of both affiliated and non-affiliated pharmacies is located on the member website. But if the intent is to deter the advertisement of one pharmacy over another, we believe that plans should encourage members to make the best use of the pharmacy networks that they build to help control costs. I appreciate the opportunity to speak again today opposing LD 1450. And I'm also happy to answer any questions from the committee at this time. Thank you.
Thank you, Mr. Hollemeyer. Are there questions for Mr. Hollemeyer? I have one, which is, it strikes me that the intent of this bill is actually to provide a consumer protection against misleading advertising. And perhaps we could word it better to do that. But Representative Tepler had a specific instance that I think was a great example. And she actually asked me what the law was, and I wish I could have remembered or stated to her exactly. But I was confused. You know, we've passed a lot of different regulations over the years. And so, you know, she ended up calling Express Scripts and finding that the letter was incredibly misleading. It led her to think that she was going to have to pay more for her prescription at a Hannaford versus mail order. And it turns out that was just false. And so I'm wondering if you could speak to this issue of misleading and intentionally misleading communications by PBMs that don't reflect, you know, what the consumer protections are that we have passed through this committee. Can you speak to that?
Yes, absolutely. Thank you for the question. And I apologize, you know, Representative or Madam Chair Tepler, on your situation. That is unfortunate and confusing, and I apologize that you had to deal with that. I can't speak to your exact specific situation without having seen the letter. Having that said, I know that typically when our member companies reach out to you to suggest switching to mail, it could be for a variety of reasons. Convenience, to where they mail it to your front door. It could be savings. It could be a variety of things, but I don't think the intent is to tell you you will be paying more if you continue in your current situation, meaning your retail pharmacy. The intent of the letter most likely would be, again, savings or convenience. But I'm happy to work with you on your letter and with one of our member companies to help clear any confusion on that bill.
Representative Tepler, we don't usually do the sort of back and forth with the sponsor of the bill, although we have done that on this committee a little bit. So I guess I'll just caution you and then go ahead and let you speak.
Yeah, I don't have any, all I really want to say is I don't think that's necessary. I spoke to them, but the letter was misleading in probably just not including enough information.
Okay.
Yeah, so I wonder if you couldn't perhaps for the work session or prior to the work session, preferably, Mr. Hollemeyer, suggest some language for us that would actually address this issue of misleading by omission, because I think that is precisely what this bill attempts to drive at, and that even extremely sophisticated healthcare consumers like myself and Representative Tepler, who've been working on these issues for years, are confused by the omission of information about what happens if they don't make the change that the letter is suggesting.
Sure, I'd
So
be happy to
I
look into that. I apologize. Go ahead.
appreciate if you could bring us back some language or a specific suggestion, because there's a real problem that I think has been identified here.
I'd be happy to look into it, Senator Sanborn.
Okay, thank you. Are there additional questions for Mr. Hallmeyer? All right, seeing none, next we will invite Chris Ossenfort to provide testimony.
I do not see her in the attendee list.
Okay. All right, I will then just ask if there's anyone else who wishes to speak in opposition to the bill. Please raise your electronic hand. And seeing none, we will ask if there's anyone who wishes to give further verbal testimony on this bill who has not yet spoken. Seeing none, I'll close the hearing on LD 1450. And we're going to go straight into LD 1481. But before I do, I just wanted to ask if our substitute clerk, hello, Jody, thank you for stepping in. If you could email the information about how to join the work session to Representative Ben Collings, that would be great.
I already have.
Okay, perfect. Thank you so much. Okay. And so next we'll open a work session, a public hearing on LD 1481, an act to clarify surprise billing restrictions. And we'll start with the sponsor, who is our own Josh Morris. Go ahead, Representative Morris.
Yes, thank you, Senator. Senator Sanborn, Representative Tepler, and distinguished colleagues of the Health Coverage Insurance and Financial Services Committee. As you know, I'm Representative Joshua Morris. I'm pleased to present LD 1481, an act to clarify surprise billing restrictions. Public Law 2019, Chapter 668, LD 2105 was passed at the end of last session and on an emergency basis without sufficient discussion of how it can work operationally. In its current form, some aspects are impractical and add to administrative complexity and costs, something I'm very concerned about. As a committee, we need to continue to focus on reducing administrative expenses that can be the result of overregulation. My understanding is that the carriers have been working with the Bureau of Insurance to address the operational challenges related to implementation of the surprise billing law, and those discussions are why I agreed to sponsor this bill. The bill has two components. Number one, it proposes a practical solution to temporary gaps in data availability at the main health data organization by creating an interim process for assessing medium network rate that would be used only until the full data set is available through the MHDO. It removes an administratively complex paragraph directing carriers to pay charges when the difference between the out-of-network provider's charge and the median network rate, including cost share, is less than $750 in certain circumstances. My understanding is that this is both burdensome to carriers and will result in higher payments to providers responsible for surprise billing. The purpose of last year's surprise billing bill was to protect consumers from surprise bills and high healthcare costs, not to increase what health plans pay to out-of-network providers. You will hear more from people coming behind me. Thank you for the time and consideration. I'll try to answer any questions I can, though they'd probably be better for the people coming after me.
Thank you, Representative Morris. Are there questions for Representative Morris? All right, seeing none, and still not seeing Ms. Ossenfort in the hearing, I will call on Ms. Pelletreau. Good afternoon, go ahead.
Good afternoon, Senator Sanborn, Representative Tepler, members of the committee. My name is Catherine Pelletreau. I'm the Executive Director of the Maine Association of Health Plans, and I'm here to testify in support of this bill. I'd like to start by thanking Representative Morris for introducing this bill for us. You heard a little bit of the genesis. We've been in conversations with the Bureau for some time about the operational details of this bill that really were never worked out at the end of last session before the bill passed. And so in our minds, we're bringing this bill forward really as a friendly amendment, maybe would be a way to characterize it. But an amendment that I think is in keeping with the committee's intent around this bill when you passed it. So it's looking for two changes. The first is a bridge to when sufficient MHDO data will be available for us to use it to implement the payment methodology under the surprise billing law. You may hear from Karen Lee, I don't know if you will today, but that data is not currently available. It just started being collected in January of this year. And it's going to take a little while for her to get enough information to be able to then feed back to carriers so that they can meet the requirements of the bill as passed. So as an interim solution, we're suggesting that carriers be able to rely on their own median network rate that they already have in-house. It would be temporary. It's just until the MHDO data is available. So that's the first piece. The second piece addresses a $750 threshold in the bill. As the bill is laid out, there is a greater of 3 logic or methodology. First, the carrier has to calculate the median network rate. Second, there's the statewide median rate, which would be determined by the MHDO when that data is available from the MHDO. Currently, it does not exist. And then third, if the difference between a provider's billed charge and the carrier's median network rate is $750 or less, the carrier has to pay the provider's billed charge. So in practical terms, that means that, a carrier just told me today, they have seen several charges of $1,100 from an emergency services provider. In this case, it was Northern Light, for a service that the median rate is roughly $500. So they're paying more than twice what the median rate is because of the $750 threshold. And we think that was an unintended consequence. We don't think that that is what the legislature intended that this bill do. We're seeing the market shift already. If you think about the types of providers that are typically responsible for surprise bills in an emergency services situation, it's anesthesiologists, it's pathologists, radiologists, those types of providers. So there's the potential for a lot of claims. So even if one instance of an additional $500 or $750 may not seem like that much, in one instance, if you think about it across that universe of claims and that universe of providers, it becomes quite a large amount. So, and the second piece is that because this is 3 calculations, it's incredibly difficult to administer. I mean, the carriers, they don't have any relationship with an out-of-network provider. So they don't know how much the charge is going to be. They cannot build an automated system that can easily do this triple calculation. So it means they're doing it manually. And that's burdensome and expensive. And we're not sure that that's what you intended either. So that's why we're bringing the bill. I mean, providers, we're making no suggestions, even though we don't really like the arbitration, we've accepted that that's what's in place. And we're trying to work within the parameters of that process. So any provider always has the ability to go to arbitration. But we think that this $750 threshold has created kind of a loophole that we think should be closed. So I'll stop there. Thank you. I'm happy to take any questions.
Thank you, Ms. Pelletreau. Representative Tepler, go ahead.
Thank you, Madam Chair, and thank you for being here, Ms. Pelletreau. If the carriers don't like arbitration, what other method of dispute resolution do they suggest?
I'm happy to take that back. I'm sure we'll be able to get a response for them because I hear a lot of complaints about the arbitration. And I know that they weren't happy with the bill as it passed. I think we would have preferred that there wasn't an arbitration process.
And so how would anything be resolved if there wasn't an arbitration process?
Well, I mean, right now the Bureau resolves it. So, but I'm happy to take that back, Representative Tepler. Thank you for the question.
Thank you.
Representative Arford, go ahead.
Yeah, just real quickly, and thank you so much for being with us, Ms. Pelletreau. What is it specifically about arbitration that the carriers have issues with?
So, Representative Arford,
I'm sorry, I'm just gonna stop there because this bill doesn't propose to eliminate or change the way arbitration works in this context. So I'm not sure that it's really on topic in the discussion of this bill to get into the discussion about arbitration. So I just, let's focus on the text of this bill, which addresses two pieces of last year's legislation, but doesn't seek to repeal the arbitration provision.
Okay, I will gladly defer to your judgment. Thank you.
Okay, all right, sorry about that. It's just a rabbit hole that we could go down and relitigate a bill that isn't in front of us, I think. Ms. Pelletreau, I wanted to ask a slightly different question, which is about the federal context. You've been very helpful in providing us with some updated information about how cost transparency regulation at this federal level has changed the background on which we write a little bit in other contexts. And I think it's extremely relevant here as well. We passed this state surprise medical billing law, and then turns out the feds pretty much just did exactly what we did. And so this is now virtually identical, I think, to federal law. So my question is, I guess I have two questions. First of all, what is it about the all claims, all payer database that we've had longer than anyone else that is new that makes it so that MHCO doesn't have the information that you need yet? Can you start there?
Yeah, absolutely. And I'd encourage you to confirm this with Karen Lee. But at issue is whether a provider is in or out of network.
Oh, I see.
That's the piece of data that has been missing. And frankly, as soon as the law passed, Karen Lee immediately went into rulemaking, and it just has started. So there's no wrongdoing on anybody's part. It just, the law passed on an emergency basis, and there wasn't enough, that information wasn't available and won't be for a little while.
Okay. But to be clear with the committee, the backstop that was in place, so there's a suggestion almost that we like missed this part in what we did last year, but actually the law had a very specific backstop in place to deal with what would happen if MHDO's data was insufficient on a particular claim. And that was an independent cost database that could be identified. So can you explain why using an independent cost database that the Bureau would identify is not an adequate solution here?
We actually think it would be adequate, and we've asked the Bureau to name a resource. They've indicated to us, and again, I'd suggest you confirm this with the Bureau directly, but they've indicated that their intention is to use MHDO. So they have declined to name an independent database.
Okay. And so then getting back to the federal question, do you know, and I wasn't able to find it quickly while I was listening to the testimony on this hearing, do you know whether the federal IDR provisions in the No Surprises Act has a minimum dollar amount?
I will look at that. One notable difference, which of course has to do with arbitration, even though the bill doesn't address arbitration, but there's no limit. There's no limit in Maine's law to the number of arbitration cases that a provider can bring, and there is a limit in the federal law. But I will look for a threshold number.
Yeah, I mean, it strikes me that the $750 was meant so that there would be a limit on the number of arbitrations. But perhaps I'm misunderstanding that piece of it. So it would be helpful if you could give us a suggestion for whether there's some other threshold. I assume at some point it's de minimis, right? You're not going to go to dispute resolution over a $30 difference, perhaps, because the cost of that process, the administrative burden of that process would be too high. But perhaps I'm wrong. Perhaps every penny is worth fighting for. But I would certainly love to know if there's some other threshold that your members are advocating for other than just no threshold, because that seems to be the opposite of what Representative Morris's testimony indicated at the beginning, which was that we were over-regulating here somehow. And this suggests we should be regulating every transaction instead of ones that are just kind of very large disputes.
Two comments. Yes, I'll definitely take that question back. And well, I won't speak for Representative Morris.
Okay. All right. Thank you. Are there any other questions for not Representative Pelletreau, but Ms. Pelletreau?
Not yet. You never know.
Not yet. Watch out. I think you live in my district, so that could be a problem. All right. All right. I don't see any others. So with that, I made myself blush. We will move on. And I will ask if there's anyone else in the meeting who wishes to speak in favor of the bill. Seeing no hands raised, I will ask for Mr. Morin to join us to testify in opposition to the bill. Good afternoon, Mr. Morin. Go ahead.
Good afternoon, Senator Sanborn, Representative Tepler, members of the committee. My name is Dan Morin, Director of Communications and Government Affairs for the Maine Medical Association. I live in Gorham. Our office is in Manchester, and we represent more than 4,300 physicians, residents, and medical students across all clinical specialties, organizations, and practice settings. We oppose LD 1481 for a number of reasons. It's all in my testimony. It was a measured and balanced legislative solution, fair to both providers of emergency services and insurers, and fully protected patients from surprise bills. The American chapter of emergency physicians in Maine wasn't completely happy with the bill either. That's the way legislation goes, but we accepted it as a compromise, and we worked diligently with the committee. And I know for a fact that Senator Sanborn herself worked very hard behind the scenes with stakeholders and members of the committee to make a workable bill and have it passed by the legislature. The groundwork would protect patients' access to care. It's only been in law for a year. It was voted unanimously by the committee, went under the hammer in the House, under the hammer in the Senate, signed by the governor in law on March 18th. The Bureau of Insurance only put out rules 7 days before Halloween, which is 174 days ago. So there's no experience. And if there is any data, we'd like to see it. Why is there a quick move to change it? Our kids have been in school longer than this rule has been in place in this law. It's not very long. This bill will recreate imbalances in the private healthcare marketplace. It'll shift leverage back to the health insurers. We oppose the removing of the backstop of an additional independent medical claims database. We talked about it last session. I don't remember the name, but it's out there. Other states are using it as a backstop to their own all-payer claims databases. And replacing that process with the carrier's median network rate is also problematic. And getting rid of that independent, transparent, and verifiable backstop database would be preferred to us, and we'd prefer it stayed in the law. Using their own data is pretty much the fox guarding the hen house, which is part of the problem we have in the first place with this process. our second to last paragraph, third to last paragraph talks about median contracted rates and how it has a ripple effect on future contracts, placing the carriers in a dominant position. I have a direct quote from the Congressional Budget Office acknowledging such in their report before the federal legislation was passed. And they say, quote, payment rates for both in and out of network care would move toward the median in-network rate, which tends to be lower than average rates. And the link is in my testimony. It's on page 20, paragraph 1. And as far as administrative costs and revenue and their books, it's no secret that national insurers are posting large financial gains during the pandemic, as opposed to physicians and hospitals who are suffering severe business impacts of the pandemic, all while treating the very patients that you're looking to protect, your constituents. I have a link to an article about their fourth quarter COVID numbers. Thanks for the opportunity to comment. We urge a vote of ought not to pass on LD 1481, and we'd be happy to answer any questions.
Thank you, Mr. Moran. Are there questions for Mr. Moran? All right, seeing none, we thank you for joining us today. Are there any other folks who wish to testify on this bill? Please raise your hand. Seeing none, I'll close the hearing and let folks know that oh, Christian's back, that we will be oh, Mr. Yardley has his hand up. Okay. Mr. Yardley, let's bring you in. Now I know why Christian's face appeared. Get my attention because I didn't see Mr. Yardley's hand. All right, Mr. Yardley, welcome. Go ahead.
Senator Sanborn, Representative Kepler, honorable members of the committee, I'm Ben Yardley. Superintendent Chapo is unable to attend the hearing because of a commitment, and through inadvertence on my part, we did not move testimony over to you. So I apologize for that, and wish to speak briefly, neither for nor against this bill. As you know, it makes several changes to that were enacted as part of LD 2105, and LD 1481 would amend the insurance code to require that carriers pay out-of-network emergency service providers at the carrier's median network rate if MHDO's data is insufficient or inapplicable to determine the fee. And it would repeal a provision requiring carriers to consider another independent database if MHDO's data was insufficient or inapplicable. And it would do two other things: repeal the provision that allows the independent dispute resolution entity to take into consideration another independent database for the reasons just described. And it would repeal the provision concerning the $750 threshold, 80th percentile of charges. So that's a brief summary, and I don't know, this bill hasn't come to your attention yet. The Bureau has submitted LD 46, which makes technical corrections to the existing surprise medical billing statute without eliminating the requirement to use another independent database. Let's see, the LD 1481 removes the alternative to MHDO from two sections. However, only section 4303-C inserted the median network rate as an alternative to MHDO. Section 4303-E, which is about the independent dispute resolution process, directs the IDR entity only to consider MHDO's rate. I cannot speak to why the bill makes a distinction between those two sections. Be happy to try to answer questions today or at the work session.
Thank you very much. And it does seem that we actually had a public hearing on that bill already.
Oh, I could be.
Yes.
There's been a lot of water over the dam.
Me too, Mr. Yardley. Me too. I was like, that sounds familiar. I feel like we already saw that. Colleen, can you help us figure out where we are?
We did have a hearing on LD 46, but we knew that this bill was being introduced, so we have not scheduled the work session yet, waiting to hear those two bills together.
Let me bravely step into the breach and suggest, as was going in the back of my mind, that it would be great to have a combined work session.
That's
well, I think we'll plan to do that, Mr. Yardley and Representative Morris. And I apologize, but I definitely have one of those moments where I was like, wait, I've seen this language before. I feel like we've talked about this language. And then I indeed saw that the public hearing was back on February 9th. So
that was an age ago.
It was a long time ago in pandemic years. In any case, we will get our ducks in a row and we will look at these two proposals side by each at some point in the next few weeks. So thank you,
That's
Mr.
an
Yardley.
expression I haven't heard for quite a while, side by each.
They make great beer in Auburn as well, in Representative Melrania's district, I think. So, okay. Are there any questions for Mr. Yardley? It's only 3:15 and I'm getting a little punchy. Okay. Thank you, Mr. Yardley. We are going to close the hearing at this point on the LD that we had a hearing on, which is 1481. And we're going to take a 5-minute break so that I can find my equilibrium again. And then we will start in on our work sessions. We'll basically take them in order. I think we'll just take them in order. And so, Christian, if you could let Ben Collins know what our plans are, that would be great. Thank you. Oh, Ben is on the call, so he just heard what our plans were. So we'll be back here at 3:20 to start our work sessions.
Okay, friends, we're a couple minutes behind what I said, but I was working on this, one of the issues that we'll be discussing today. So if folks are within the sound of my voice, they can pop their video on and join us. Great. So the first bill that we will pick up for a work session is one that we have worked in the past. It is LD 984. And I just wanted to say that the Bureau has issued the bulletin. This is an act to allow procurement of surplus lines insurance for commercial forestry and construction equipment. And the Bureau was planning to issue a revised bulletin with regard to what the rules were around procuring surplus lines insurance in this context. They have done so. And I checked in with the sponsor and he's happy with the bulletin as long as it stays in place. So he wanted me to try and emphasize that it should not be taken away by any future insurance bureau, but that as long as it stays in place, he was happy with it without a legislative solution. So I would move ought not to pass. Is there a second? Representative Tepler seconds. And is there any further discussion on the bill? All right, we'll ask the clerk to call the roll.
Representative Quint.
Yes.
Representative Quint, yes. Representative Connor. Representative Connor is absent. Representative Blyer.
Yes.
Representative Blyer, yes. Representative Morris.
Yes.
Representative Morris, yes. Representative Matheson.
Yes.
Representative Matheson, yes. Representative Evans.
Yes.
Representative Evans, yes. Representative Arford.
Yes.
Representative Arford, yes. Representative Melorano.
Yes.
Representative Melorano, yes. Representative Brooks.
Yes.
Representative Brooks, yes. Senator Stewart. Senator Stewart is absent. Senator Brenner.
Yes.
Senator Brenner, yes. Representative Tepler.
Yes.
Representative Tepler, yes. Senator Sanborn.
Yes.
Senator Sanborn, yes. That is 11 yes, 2 absent.
All right, next we will pick up LD 1150, an act to eliminate insurance rating based on age, geographic location, and smoking history. And I'm going to ask Colleen to present her bill analysis for us.
Okay. Whoops, I had the bulletin pulled up, which we didn't need. LD 1150, as Senator Sanborn said, seeks to make changes to the existing insurance rating laws based on age, geographic location, or smoking history, and to reduce rate variability due to group size. As it's drafted, it seeks to prohibit insurance carriers providing individual or small group health plans from varying premium rates based on age, geographic location, or tobacco use on or after January 1 of 2022. The bill also would reduce permitted variation based on group size from 1.5 to 1 for small group plans over time. As I mentioned, there are current provisions in the insurance code that also mirror some of the federal law requirements under the Affordable Care Act. So currently, health insurance carriers providing individual and small group health plans may vary rates on the basis of age at a ratio of 3.1 and that 3 to 1, excuse me, and that is consistent with the requirements under the ACA. If the restrictions in the ACA, and I think this is a question maybe to be clarified by the Bureau of Insurance, but there are existing provisions in the insurance code that may permit age rating up to a 5 to 1 ratio. Rating on the basis of tobacco use is addressed separately. And again, that's consistent with the Federal Affordable Care Act. So carriers may vary their rates up to 1.5 to 1 on the basis of tobacco use. The federal ACA does allow unlimited variation for geography, but Maine law does limit geographic variation to a 1.5 to 1. And it says ratio here, but it really, the statutory term that's used particularly for geographic area is a rating factor. So the rating factor that's permitted for geographic area is 1.5. As I mentioned, the bill as drafted would prohibit rating on the basis of these allowable rating factors, age, tobacco use, geographic area, that are currently recognized under the ACA. The federal law does permit states to adopt more restrictive rating rules. And there are a few states, 3 states, that have more restrictive rating factors for age. That would be less than that 3-to-1 ratio in the ACA. And there are 10 states and the Washington District of Columbia have eliminated or imposed further restrictions on that tobacco rating factor that I mentioned. Rating on the basis of group size is not permitted under the federal ACA. So if the proposal does move forward in some form, those provisions in the bill should likely be removed. So one of the sort of policy questions, I guess, for the committee thinking about the proposal in LD 1150 is really the effect and the impact on premium rates and any potential disruption to the market, and also considering any effect of adverse selection, particularly right now because there is an absence of an individual mandate, particularly to purchase insurance. And one of the questions that was raised, that if the committee is interested in moving forward and doing something like this, eliminating these rating factors, that it really is something you might consider requiring some further study on before moving forward. As the bill's drafted too, as well, from a technical standpoint, since the provisions would be in place for the January 1 of 22 plan year, there were some concerns raised by the Bureau of Insurance about the timing and ability to implement this type of proposal. And lastly, I would just say the committee has considered most recently in the 129th and the 128th legislatures, similar proposals that were before the HCIFS committee, and those proposals were not enacted. And then I would just remind you that the committee did have public hearing on a bill LD 1331 sponsored by Senator Stewart, that we did have the hearing on subsequent to the original work session date for LD 1150, but that bill LD 1331 proposed specifically to make some changes to the geographic area rating factors in our current law. And I'll stop there, and I'm happy to answer any questions. I think I'll stop sharing as well.
That would be great. Thanks, Colleen. And I think it might actually, and there is this question. Can you guys still hear me?
Yes.
Okay. There is this question about age rating factors, whether in the absence of the Affordable Care Act, we would revert to 5-to-1. So Colleen, can you share your screen with that statute as amended last year? Well, 2 years ago now in the LD1 of the 129th, I think dealt with this, but I want to share the text of that and talk to Mr. Yardley, maybe bring Mr. Yardley in to see if I am correct, because this I think came from his testimony.
Yeah. So here, I think everybody can see this, right? What I'm sharing is
small.
Yeah, I'm gonna try to see if I can zoom it, but because it's my I don't know if I can zoom it out because it's the
okay.
I'm not as good. Oh yeah, here I can zoom it up. Is that better?
Yes.
Oh gosh, I hit the wrong button. I'll do it again. Sorry about that.
Christian, will you bring Mr. Yardley in as well while Colleen's working on that?
I did the wrong thing. I got it. I'll pull it up for you again. Here we go. Oh. Now because it's so big, I can't see it myself. Okay. It's too big, I can't forward. Okay. There we go. All right. So I am going to share the statute now.
I made this much more difficult.
There we go. Okay. So no, that's fine. So I think you can see I'm sharing for purposes of just illustrating it right now. I'm sharing the requirements related to individual health plans, although there's corresponding provisions for small group health plans as well. And the provisions related to age rating is in paragraph D here. And I think the question that Senator Sanborn wanted to ask about was the relationship between subparagraph 7 and subparagraph 9. Is that right?
Yeah, I guess my question is it not the case that in the 129th legislature, we actually did make it so that if the ACA went away, 3 to 1 is still the most variability you could have with regard to age under Maine law. And Mr. Yardley, since it was your testimony, I just wanted to see if we're missing something in the nuance of the statute, or maybe it was just an oversight because LD1 is pretty new.
So can you hear me?
Yes.
Oh, okay. I will try to answer the question. I think that, could you rephrase it for me? I got lost while I was looking at the statute.
Sure. Your testimony just was that in the absence of the ACA, Maine would revert to 5 to 1, which is what our ratings band was prior to the ACA. But I don't believe that's the case because of section 9 of this this statutory language. So I just wanted to see if we were on the same page or if we were missing some nuance.
So I'm going to, I don't know the answer to your question. So
okay.
If you could give me a couple of minutes to
sure, we can move on
with my WIN people.
Yeah,
I think
move.
the superintendent will be on shortly also.
Okay. We'll move on from there. I'm pretty sure that that was included in LD1 in the 129th. So I just wanted to that was probably more complicated than it needed to be. But because we had direct testimony from the Bureau to the opposite effect, I just wanted to make sure that we were on the same page. If we're not, come on back to us, Mr. Yardley. If I'm right and we took care of this last session, we're all set. And it was just
okay. Great. Thanks.
Okay. Great. And Ms. Awesomefort has her hand up, but if she just wants to confer that we did that, she can just put her hand down. If she has a different answer, leave your hand up. And okay, great. Okay. I think we're good. All right. So we've kind of made the age point, I think, which is that it mirrors ACA and it's not 5 to 1 anymore in Maine law. Okay. Next, I want to call on Representative Brooks since it's her bill and she can give us an idea of where her mind is at right now.
Okay, with LD 1150, so I'm glad that it's 3 to 1 instead of 5 to 1. But I'm focusing more on testimony provided by American Cancer Society, Cancer Action Network, and the American Heart Association. And I think of the rating factors. Smoking is the one that people can't get subsidies for that increase in their premiums. So if their premiums are 1.5 times what it would normally cost, and they were on an Affordable Care Act plan, it wouldn't be covered by additional subsidies at all. Whereas like with age and geography, the Affordable Care Act does help make up subsidies for people within certain income limits up to 400%. So where I'm focusing more on the bill going forward is to phase out the smoking rating, maybe push it back a little bit to 2023 and have it go to 1.25 and then subsequently the next year off to be just a 1-to-1 ratio. I think it's a dangerous practice that we have to have people that might cost more or to have them pay a higher premium. But with this one in particular, it's a harder blow to people that can't afford their premiums. And I can understand kind of the slippery slope that it's on is that we're taking people that may be arguably at risk for other diseases, but at the same time, they have a medical issue in my mind that it can be helped with encouragement to quit smoking, and it can be helped with smoking cessation programs. And a lot of people, they try to quit a number of times, but it's well worth it if they are successful. So I'd like to kind of focus on that area of the bill when we go forward. And I don't know if there's any more discussion before I had made a motion to table.
So let me just clarify, make sure the committee is following it. Representative Brooks has suggested that an amended version of her bill going forward would be just the tobacco provision, and that it would phase out tobacco rating in 2023 to 0.25, and then in 2024 to be eliminated entirely. And then the rest of the bill would fall away. Representative Brooks, have I articulated that well?
Yes.
Okay. Representative Tepler, go ahead.
Thank you, Madam Chair. And I just want to say that I'm supportive of this idea because I believe that we actually end up being penny wise but pound foolish if we drive smokers away from insuring themselves. If smokers choose not to get insured because their costs are higher and they get cancer down the road, we're paying for that. Whereas if they are insured, they'll have access to smoking cessation programs and all kinds of things that their insurer will provide to help get them off of nicotine and tobacco. And so I'm convinced that it's really important to get smokers into insurance, and eliminating the rating over time is a way to do that. On the other hand, I also want to say that I don't want to interfere with the work that we've been doing on the small group and the individual market. And so that's one reason why I'm supportive of Representative Brooks pushing this out a ways. Because right now, the work that's being done by the Bureau of Insurance and DHHS to apply for waivers really needs to take some precedence. And when we get a little further out, we can monkey with these ratings to help smokers be insured.
Representative Morris, and just to clarify, so our intention is to table this bill, having suggested this, this idea just sort of out of the blue. So our intention is to table it today, but I'm interested in getting more discussion on the table before we do so. And then we'll line it up with Senator Stewart's bill when we work those in the coming days. Representative Morris, go ahead.
Yes, thank you, Madam Chair. And I understand the intent is to table this today. And so I don't want to go on for a long time, but that is a non-starter for us. I think there has to be some responsibility. We have years of data and evidence that says smoking is bad, and it's bad for your health. And I think to eliminate the rating factor is not good policy. I think that all that's going to do is cause people that are non-smokers, such as myself, to have to pay a higher rate in the individual and small group market, and it's eventually it could lead to adverse selection within those markets. And so for those reasons, we will not be supporting anything around reducing the rating for smoking.
Are there any other comments on this bill? All right. Yeah, Colleen, you had a question.
Yeah, I just wanted to clarify. I think Representative Tepler clarified it, but my understanding of what Representative Brooks was talking about is that the current rating factor of 1.5 to 1 would stay in place through the end of 2022. And so beginning 21-1-23, you'd reduce it to 1.25 and then eliminate it in 2024. Okay. So I'll draft this up so we'll have it for you to review when we have our next work session, but I just wanted to clarify that. Thank you.
Great. Representative Brooks.
Colleen, I was just going to ask as well, if you could pull up a chart that shows how the rating factors, how much they would cost relative to different income levels, or I know a couple of years back, you were able to produce some sort of document that said, examples of what certain rating factors would do in different geographic areas, or like focusing on the smoking though, but I don't know if that's easy for you to put your hands on or not.
Okay, I can try to pull some examples together. Certainly under the existing statute, we can pull some cost calculator, get some examples of what it would cost now, and then we can just plug in the different rating factor. So I think that will be, I'd be happy to provide some examples, and Bureau of Insurance has helped with that in the past. They may be able to do that as well.
Yeah, they did give in some of the testimony from the American Cancer Society, Cancer Action Network, and or the American Heart Association. They did give at least one example. So
yes, yep, sure.
Thanks.
Okay. So not seeing any other hands up. Representative Brooks, go ahead.
Yes, I'll make a motion to table LD 1150.
Is there a second on the motion? I see Representative Evans's hand up, and we can vote on a motion to table with just hands in the box. Representative Morris was eager. And so Representative Arford, did you want to vote? Is your hand up? Okay, great. Thank you. Okay, so it's unanimous to table of those present. Okay, so moving on, next we will open a work session on LD 1151, and I think Representative Collins wanted to be recognized because I think the bill has changed a little bit, or his suggestion had changed.
I'm pulled over in a parking lot. Can you hear me?
We sure can, Representative Collins. Go ahead.
Okay, thank you. I'll be very brief. I have two bills today. So just to confirm, this is the bill dealing with the cost of prescriptions and healthcare plans, right?
Yes.
Okay, thank you for that clarification. So what I wanted to ask of the committee, and really technically asking the Superintendent Choppa's office, but involving the committee to do so here today, was, from what I understand, is he's going to be having a report coming up in the near future. And what I believe was said to me was that actually, to some extent, in group plans, when they negotiate prescriptions, that now that saving is going to be passed on to the consumer, not to the company that manages that plan. And so if that's the case, I wanted to ask the committee and the superintendent to consider the following. First is consider maybe delaying action on the bill to get clarification on that, to see if that is fully passed on to the consumer. And second, regardless of that first point I made, I wanted to request, if it's not too late, or if it's too late for this year and future years, for the superintendent to look at what the actual cost is in that savings. So the total savings, if that could actually be, if that could somehow be quantified, the actual savings when of all the companies that negotiate prices, and that total savings, the discount for prescription drugs, what that total amount is, and what that saving is. And so if we're looking at maybe working in the future to plans that deal with the deductibles and high costs for people that pay a lot for prescriptions, what that amount is when we negotiate the price. So I was looking to get some sort of feedback on that, if possible.
Okay, Representative Collins, thank you for that suggestion. I think there are probably a couple of different answers to your request. They're covered by either existing law and reports, or by other bills that we have pending that are directly on point with what you're talking about. So let me give that a stab just in the interest of time. I think the first one that you're talking about is the report on the PBM bill, LD 1504, which passed 2 years ago. I'm pretty familiar with it because I was the sponsor and author of it. And it does require that rebates be passed along, that the savings in rebates be passed along to consumers, and that they be passed through to either reduce premium or directly at the point of sale to reduce out-of-pocket costs. We are, I think, expecting a report on that, which is probably what you were referencing in terms of the report that is coming soon. So I'll just check in with Colleen with regard to a PBM report. Is there a PBM report coming soon, Colleen, that you're aware of?
I'm just looking back quickly at the statute. The statute requires that carriers file their annual reports with the Bureau of Insurance about how they've addressed sort of the rebate issue that you've talked about on an annual basis. And that first report was due to the superintendent in March 1 of 2021 and annually thereafter. There's nothing in the allocated statutes about a report back to us, but I'm going to try to quickly look at LD 1504, which was the actual public law, to see if there was an unallocated.
I think there is. I think there's allocated language about a report.
Right. I believe so. And I'm just trying to, I can confirm the date of that.
Yeah.
When that comes back to the committee. So those reports have just started to come into the Bureau of Insurance in March of 2021. So
right. To be clear, Representative Collins, that bill went into effect last January 1st. So it has not been in effect, and it only applies to contracts as they're renewed. So it's not been fully implemented even for a full year yet. So we're still collecting data on it, but there is data collection as part of the bill and part of the enforcement scheme. I guess the other thing that I would point out is that we have done a lot on prescription drug price transparency, and we have a number of bills that continue to incrementally make progress in that direction. And I think that's the other piece of what you were just talking about, trying to sort of wrap our heads around what the total amount of savings is. So with that context, Representative Collins, are you satisfied that we sort of already have either other vehicles or reports that are actually already in process, that we will certainly be continued to focus on prescription drug costs, but I'm not sure that your bill helps us move that needle forward at this stage in the game. But
yeah, I would hope that there's things that the law you referenced that you sponsored that was passed last session, any ongoing efforts, I would hope that we would continue to look at this as the main legislators and specifically find ways. I mean, I was just giving an example. If there was discounts going to health plans, perhaps that could help offset if there would be increases to plans to add a new benefits in the essence of what my bill described, which was to give the option of having some plans for the case of individuals that might have to pay $800, $1,000 a month in pharmaceutical prices. So anything that that has passed, that will continue, or anything that you're working on this session, I hope that it can address this issue, and that there could be a way that we could get to what the intent of this bill is to offer consumers a plan where they're not burdened to such a great extent on people with cancer or other illnesses that they're paying so much out of pocket for their prescriptions that it's just like becoming a crisis for them and many, and that's what I'm really getting at. So
okay, well, thank you for bringing us that concern. It's certainly one that is shared by the entire committee and that we work on diligently and will continue to do so. So we appreciate you bringing the issue and highlighting the issue again for us. Colleen, were you able to find that unallocated language?
There isn't any unallocated language in LD 1504 specific to that piece of it that I could see, but there are certainly other reporting aspects, and the Bureau is receiving those reports, and we could certainly ask them to aggregate some of that information for us, I think.
Okay, great. Representative Tepler, go ahead.
Thank you, Madam Chair. I think it would be great to ask for a report back from the Bureau. We don't need to put it in statute in any way, to let us know what's happening with compliance with the PBM law with 1504, and if they can report any results that are helpful to consumers, that would be great.
Yeah, I think that's fair. We can make a letter. And I think again, I feel a little bit like Groundhog Day. I think we talked about this in February, and I think we asked them to do that then, which is why I think there's a report coming. So I apologize for my inability to remember all the details, but I do think we've chatted about this issue on this year on Zoom. So we'll have Colleen just double check with the superintendent's office that we didn't already send them a letter about this, and we'll go from there.
I won't double up. I won't double up with letters.
Thank you. All right. So with that said, I'm going to move on not to pass, but thank the sponsor for bringing this important issue again to the forefront. Is there a second? Representative Quint, thank you. And the clerk will call the roll.
Representative Quint.
Yes.
Representative Quint, yes. Representative Connor. Representative Connor is absent. Representative Blyer. Representative Blyer is absent. Representative Morris.
Yes.
Representative Morris, yes. Representative Matheson.
Sorry, can you come back for me, please?
Yep. Representative Evans.
Yes.
Representative Evans, yes. Representative Arford.
Yes.
Representative Arford, yes. Representative Millerano.
Yes.
Representative Millerano, yes. Representative Brooks.
Yes.
Representative Brooks, yes. Senator Stewart. Senator Stewart is absent. Senator Brenner.
Yes.
Senator Brenner is yes. Representative Tepler.
Yes.
Representative Tepler is yes. Senator Sanborn.
Yes.
Senator Sanborn is yes. And now Representative Matheson.
Sorry about that. Yes.
Representative Matheson, yes. That is 10 yes, 3 absent.
Okay. So the next bill is also Representative Collings, and I think he's still with us. Just turned his video off in his car, so that's fine. It is LD 1281, an act to prohibit discriminatory practices in certain health insurance policies. And I believe that at the hearing on this bill, he did suggest an amendment. Colleen, maybe we'll have you walk us through I haven't looked at your bill analysis, but why don't you go ahead and open that and we'll start there. I think you're on mute or else you're not talking.
Oh, here we go.
There you
okay. I'm just trying to hide all so you can see everything. Is this big enough for everybody, or should I try to zoom it up a little more?
I think it's fine with the tools pane shut.
Okay, yeah. So yes, as Senator Sanborn said, Representative Collings introduced an amendment in advance of the hearing to replace the bill. And so the analysis of what's here for you is the bill as amended upon Representative Collings' suggestion. And so his proposed amendment would require the superintendent of insurance to report on a number of items related to employer participation in the small group market, including some demographic information, the total number of employers in Maine, the total number of small employers in Maine covered during the calendar year, number of eligible employees for those groups, and the number of enrolled employees in each small group. It would also require some reporting on trends in the small group market related to standardized plan designs, such as the Clear Choice plans that are being developed by the Bureau of Insurance. Also, some reporting on changes in participation in the regulated small group market compared to the non-regulated market. And I think what he's referring to here is fully insured small group plans and those small group plans that might be self-insured with employee excess benefit insurance on top of that. Would also direct the superintendent to look at the impact of making changes to the definition of small group. Our current law defines a small group as 50 or fewer employees. And the language of the amendment would look at changing that definition, increasing the size to either 2 to 99 employees or 2 to 75 employees. And then also some specific information from carriers offering employee benefit excess insurance to small group employers, detailing some information from the previous calendar year about where the carrier declined to offer coverage in any instances related to premium increases related to that. A couple of things I guess I would note about Representative Collins' proposed amendment. The amendment does specify that the superintendent report on an annual basis, yet some of the specific items that I just mentioned, asking the superintendent to do some analysis, seem to be more one-time items. For instance, the study of the impact of changing the definition of a small group. So if you do move forward, you might consider sort of restructuring the amended language to separate sort of those ongoing reporting requirements from any one-time analysis or reports on specific issues. As you also heard at the public hearing on this bill, this committee has previously considered some legislation related to the availability and use of employee benefit excess insurance or stop-loss insurance in the small group market, and the impact that's had on the small group, fully insured small group market. There were 2 bills from the previous 2 legislatures that were considered by the committee that would have prohibited insurers from selling stop-loss insurance to eligible small group employers, but those bills were not enacted. Instead, the committee requested that the Bureau of Insurance adopt a rule updating and outlining some criteria for issuing employee benefit excess insurance. And the Bureau of Insurance, in response to the committee's request, did update their rule and adopted Bureau of Insurance Rule Chapter 135 in September of 2019. That rule does already require carriers to annually report to the Bureau of Insurance some of that demographic information I mentioned, including the employers in Maine covered during the calendar year that have employee benefit excess insurance, the total number of small employers covered, the number of eligible employees, the number of enrolled employees in each small group, and the attachment points for each group. So just to make you aware of that activity. And then lastly, just sort of technical changes if you do move forward. There's no specific reporting date in the language that Representative Collins provided, or a specific authorization to the legislative committee to report out legislation to a specified session. It does seek to provide authority to the legislature to report out a bill in response to the Bureau's report, but it doesn't specify that. So I'll stop there, and I'm happy to answer any questions. I could also share the rule if that's appropriate.
Thank you, Colleen. Colleen, again, I guess I have a question about reporting requirements back to us. It's my understanding and recollection that that employee benefit excess insurance rule that we asked the Bureau to implement, also that statute also requires they report back to us. Is that your recollection as well?
It did, but I think they already satisfied that requirement last session about the rule and the their plans for implementing the rule. We asked for some specific report back of sort of my understanding is that was a one-time report, but the rule that's in place now, Rule Chapter 135, does have, as I said, specific reporting by carriers to the Bureau of Insurance. And again, if there's any specific information that you would want to aggregate or ask the Bureau of Insurance for, you could certainly do that. But I don't think there's any specific reporting requirement to the legislature in the rule itself.
Got it. Okay. Representative Tepler.
Thank you, Madam Chair, and thank you, Colleen, for your analysis. It appears to me that we already have a lot of this information as a result of the application for the 1332 waiver that the department was working on, that would have combined the small group and individual markets, and that we've talked about some of this before. Am I correct about that? I see Senator Sanborn sort of.
Well, I think it's mostly in the employee excess and benefit insurance bill rather than in the merged markets context. And I don't think the Bureau's ever done a study on expanding the group definition. But I'm also not sure it's the time to do that, given the other conflicting things that we're asking them to look at with regard to the merger of the market. But Mr. Yardley might be able to shed some light, because I thought he was going to report back to us. I feel like, again, I remember things that maybe didn't happen, but I thought that he had actually, or perhaps Superintendent Chapa had actually cited some numbers about number of employees who are covered by employee benefit excess insurance and how stable it has been over the last 2 years. I seem to recall that from the hearing. So perhaps we could bring him in and he could talk with us about the timing of when we might get a report on that piece. Colleen's nodding, so that means I didn't entirely make up the idea that.
No, I think that's right. The superintendent did provide some information about the stability year to year about who is in the employee benefit excess insurance market.
Okay, Mr. Yardley, you may be at a disadvantage because you are not Superintendent Chapa, but I didn't know if you had anything that you could give us as information with regard to whether we're going to see a report about the stability in the employee benefit excess insurance market.
I think I'm wearing a Ben Yardley mask on Zoom,
yeah.
But I've.
All right.
Oh, there are two Ben Yardleys now.
That's okay.
Yes, the reviser decided to do some funky things with the statute. Rather than repealing 5-1, what the reviser did was say that except as provided in the most recent thing in the long history, it's 5-1. But
okay, we got it. I think we have answered that question, and we're on a different bill now and on to a different question. So my question might actually be for the real Ben Yardley at this point. So I'm gonna swap you guys here. If the real Ben Yardley would please turn his video back on and answer our question about the employee benefit excess insurance report, please.
Yeah, I did go back and look at my notes from the superintendent. I think he talked about the difference between 775.99 and 79.50 in terms of the number of small groups. But I don't know if Ben can confirm that.
Now I have no Ben Yardleys. I have two Ben Yardleys, but neither of them is speaking. I've just given them both the ability to. There you go. Oh, you're on such delay. All right. You were off of mute, but now you're back on mute. And there's a huge delay. So I think we may have some technical issues here that aren't really working to our advantage. We can't hear you, Mr. Yardley.
Can you sign?
Do you know? We can't hear you. We can't hear you. We still can't hear you. We almost can read lips now, but we really can't. All right.
Evidently, you can't even hear me speak. So.
All right, now we can hear you. Okay, we can hear you now, sir. So do you know if there is a report?
You can?
Yes.
Because I can't hear myself, and I can't hear. I can only hear you through a telephone that Superintendent Chapa has running, and I'm sort of trying to do two things at once with you folks. Yeah, what a mess.
I think the telephone is giving you a long delay. The problem.
Do you, Eric, are you still there? Ugh. I've lost
Okay.
him now. I'm
All
afraid
right.
I'm of no help to you.
Okay. All right. No problem. We're gonna proceed because
Maybe the fake Ben Yardley can answer a question.
I'm not sure he could hear us either, to be really honest. So yeah, okay. All right. Usually we don't have so many technical issues. I apologize. I'm not really sure what's happening. I think maybe Mr. Yardley's speaker and microphone are two different sources. That sometimes happens to me. But it's hard to tell him how to fix it when he can't hear me.
Hi.
Okay, all right, no problem. We're gonna proceed. Okay. Now I'm listening to all of this over again. So we're just gonna put him back through the wormhole. I'm just pushing people back over to the wormhole, and we're gonna go back to the committee process here. And I'm just gonna suggest that I believe that this data that Representative Collins is asking for all exists in the hands of our insurance bureau, with the exception of the study of changing the size of the markets. But that given the other asks that we have made statutorily to move toward a merger in the other direction, it's not a great time to be asking for that report at this moment. So that is going to be my suggestion on this, and I will recognize Representative Tepler.
Thank you, Madam Chair. I am absolutely sure we had a discussion with the Bureau concerning the small group and concerning whether or not they had studied the increasing the small group to 50 or 100 even, we talked about. And they said they had chosen to go the other direction rather than doing that, and that would require another whole actuarial study. And I can't remember what else the superintendent said about it, but he did say some other kinds of negative things about that approach as opposed to the one that was chosen.
Okay, Representative Evans, go ahead.
Okay, just for clarification for my purposes, even if they have done the study or if they have not done the study, what kind of a time frame might we be looking at?
I'm not sure what the question is. A time frame for what, Representative?
For a report from the Bureau to answer the two separate questions. Even though it seems like we know that they may have already done the work, and if they have to do the work, haven't done it, what's the
So to clarify, Representative Evans, there's two issues, I think. One is about employee benefit excess insurance. We know that they are collecting that information, and that Superintendent Chapa previewed what he described for us as a report that was sitting in front of him that was in its final draft form.
That I remember, yes.
And
yes.
So that's one piece. So that takes care of most of the paragraphs of Representative Collins' draft amendment. The paragraph that is not dealt with is the 2 to 75 or the 2 to 99 change. But that policy consideration of should we change the size of the small group market is a policy consideration and discussion that we had last session, and we asked them not to do that. And instead, we asked them to focus on merging the markets, the individual and small group markets, and applying for a 1332 waiver. And we passed a statute requiring them to do that. This would pull them in the other direction, and it would set a conflicting policy goal versus what is in statute today. So it's not a report that I want them to do right now, because we've already asked them to do the opposite.
Okay, so it's already done. I'm sorry, I got it.
It's not that we have the answer, it's that we asked them not to look at it a year ago.
Okay.
And to look at something else instead, which they're still in process of doing. Representative Collins, you had your hand up and it is your bill, so I want to give you one last word.
Oh, I think my hand's down now.
Okay, if you're all set, that's fine.
I like, for the record, non-related to this bill, I see that there are many Ben Yardleys here, but don't forget there's only one Ben Collins. So.
Okay, excellent. So with that final word, I'm going to move ought not to pass. Is there a second? Senator Brenner has seconded, and we'll ask the clerk to call the roll.
All right, Representative Quint.
Yes.
Representative Quint, yes. Representative Connor. Representative Connor is absent. Representative Blyer. Representative Blyer is absent. Representative Morris.
Yes.
Representative Morris, yes. Representative Matheson.
Yes.
Representative Matheson, yes. Representative Evans.
Yes.
Representative Evans, yes. Representative Arford.
Yes.
Representative Arford, yes. Representative Millerano.
Yes.
Representative Millerano, yes. Representative Brooks.
Yes.
Representative Brooks, yes. Senator Stewart. Senator Stewart is absent. Senator Brenner.
You have to unmute.
Yes, sorry, my cursor got lost.
Senator Brenner, yes. Representative Tepler.
Yes.
Representative Tepler, yes. Senator Sanborn.
Yes.
Senator Sanborn, yes. That is 10 yes, 3 absent.
Okay. One left. It's not even 4:30 yet, friends. We're good. Okay, so the last bill is LD 1320. It is an act to allow main shareholders of banks and members of corporators of credit unions to hold virtual meetings. It's pretty straightforward, but I'm happy to have Colleen do the bill analysis. It's not straightforward, Colleen?
Oh, no, I was just going to say, yeah, I think it is. The amendment, I can share the amendment, but the amendment just really adds credit unions to reflect the title of the bill. And there was no opposition to the proposed amendment by the Bureau of Financial Institutions or the associations.
Okay. Senator Brenner?
I would vote ought to pass as amended.
Second.
Okay, so we have a motion and a second. Is there any further discussion on the bill? All right, seeing none, I'll ask the clerk to call the roll.
I was writing it down. Representative Tepler, you seconded? Okay.
Yes.
Okay. Representative Quint.
Yes.
Representative Quint, yes. Representative Connor. Representative Connor is absent. Representative Blyer. Representative Blyer is absent. Representative Morris.
Yes.
Representative Morris, yes. Representative Matheson.
Yes.
Representative Matheson, yes. Representative Evans.
Yes.
Representative Evans, yes. Representative Arford.
Yes.
Representative Arford, yes. Representative Millerano.
Yes.
Representative Millerano, yes. Representative Brooks.
Yes.
Representative Brooks, yes. Senator Stewart. Senator Stewart is absent. Senator Brenner.
Yes.
Senator Brenner, yes. Representative Tepler.
Yes.
Representative Tepler, yes. Senator Sanborn.
Yes.
Senator Sanborn, yes. That's 10 yes, 3 absent.
All right, that's pretty good, guys. So that's 4 more down out of the 100 that we had left. So we'll just keep chipping away at it. Representative Evans, go ahead.
I just wanted to make a point that I have not had so much fun and I don't know how long.
Well, we got some work done and we laughed at ourselves, and really, what more can you ask in life? So okay.
I do have 2 more language reviews.
A little bit more.
All right, Colleen's got some language review for us.
I just have two quick ones that I'll just share, LD 600 and LD 653. So I'll pull them up here. I'll do LD 653 first. This bill was voted ought to pass by the committee, but we didn't yet have our fiscal information. We've received that from the Office of Fiscal and Program Review. No fiscal note required, no fiscal impact, so it will be reported out ought to pass.
Excellent. We never get to do that.
I know, not very many.
Congratulations, Representative Arford.
Right, ought to pass with no amendments. Go ahead.
Oh gosh, all right. And
Thank you all, by the way. That was my very first bill ever.
Woohoo.
Ever.
And then the second one, this was Senator Brenner's bill, LD 600, ought to pass as amended. This was the bill requiring insurance coverage for certified midwife services, adding them to the current law that recognizes nurse practitioners and certified nurse midwives. The printed bill had an application effective date of January 1 of October 1 of 2021. The amendment changes that to January 1 of 2022, consistent with what we have previously done with other legislation. And so that just, this is second page, is just the markup changing the date to January 1 of 2022. And then the fiscal impact statement, no fiscal impact. So LD 600 will also be reported out, ought to pass as amended.
Great. Are there any questions or concerns on any of those? Seeing none, are there any announcements? Representative Tepler.
I just want to ask Colleen, do you think those will go up quickly enough that they'll be under the hammer when we go into session next week?
Most likely. I don't know how quickly they're sort of moving them up to the calendar, but they will be reported out of committee today or tomorrow. I expect Friday at the latest. So like I said, I just don't know how quickly or when they're closing the calendar, but I expect they could be available for the consent calendar, or whatever it is you call in each house or body. The ones for unanimous committee reports.
The House calls it the consent.
Right. The Senate doesn't, right? I knew there was some distinction. Yeah.
What does the Senate call it?
I don't even think they call it.
I think it's just a section of unanimous reports.
Right. There's some distinction, but anyway, I think they will. I can follow up and let you know if they wouldn't. Thanks.
Okay. Representative Matheson, are you just waving goodbye? You're just waving goodbye. Okay. Are there any other comments? This is the fun committee, by the way, guys. We have way more fun here. Who would have thought health insurance is the place to be? All right. Anything else?